Good afternoon and welcome to the second day of this two-day public workshop on identifying key competencies for opioid prescriber education. I'm Mark McClellan, director of the Duke-Margolis Center for Health Policy at Duke University, and we're convening this workshop under a cooperative agreement with the U.S. Food and Drug Administration. During this meeting, we'll bring together a wide range of expert stakeholders to consider how the content of education for prescribers of opioids, as well as other providers involved in the management of patients with pain, can be improved, updated, and aligned in the context of the evolving opioid and substance abuse crisis. As we move on to the next slide, I'll go over some of the key topics that we covered yesterday, and then we're going to look ahead to the plan for today. We opened yesterday with presentations from FDA and SAMHSA reviewing recent and relevant work by the federal government in the prescriber education space related to opioids and pain management. Dr. Patrizia Cavazzoni, director of the Center for Drug Evaluation and Research, started us off with a high-level overview of FDA's current thinking about the evolving situation involving opioids and substance abuse crisis and opioid prescriber education, what we've learned about it in that context. Mark Liberatore of FDA then reviewed the context of the opioid analgesics REMS blueprint, which aims to educate healthcare providers on best practices for treating acute and chronic pain, as well as key elements of addiction medicine, such as identifying and treating opioid use disorder. Then we heard from Ingvild Olsen, who described some of SAMHSA's key work in prescriber and provider education, highlighting the wide range of training initiatives such as the provider clinical support system, the opioids response network, the Rural Opioid Technical Assistance Program, and SAMHSA's Addiction Technology Transfer Centers, all of which provide a diverse set of resources intended to be tailored to particular provider needs related to treating patients with pain or opioid use disorder. Then we moved on to presentations and panel discussions on key topics in this space. The first one focused on core competencies in prescriber and healthcare provider education. Eric Holmboe gave us an overview of the National Academy of Medicine's recent core competency framework, as well as some additional core competencies identified by ACGME's Stakeholder Congress. And then our first panel expanded on that introductory set of remarks to discuss core competencies that they felt should be familiar to all providers, emphasizing the ability and the skills needed for communicating with patients in a way that builds trust and reduces the stigma that often surrounds both pain management and opioid use disorder, and how to use evidence-based tools to screen for opioid use disorder and refer patients and support patients in further treatment if needed. The panelists also described some of the difficulties associated with getting these core competencies established, excuse me, while still allowing for the necessary flexibility of diverse types of providers and practice settings and patient needs. We also heard that while early intervention at the graduate level is crucial, behavior modeled by practicing providers has a big impact on new providers and on existing providers, reiterating the importance of educating all providers and helping all providers keep up to date on these core competencies. Then on our last presentation of the first day and the panel discussion, we focused on professional practice gaps in knowledge that might be addressed by improvements in provider education. Kathy Chappell highlighted some key gaps in provider knowledge and practice that were identified by that National Academy of Medicine's Action Collaborative as part of a comprehensive literature and landscape review. Among the key gaps that were noted in that literature and landscape review were appropriate prescribing, ongoing monitoring, and effective opioid tapering. Often, these gaps were found to be rooted in lack of clinical knowledge, as well as in provider attitudes or biases. The subsequent panel discussion after her presentation explored these topics further, highlighting the importance of effective provider-patient communication, multimodal and non-opioid approaches to pain management, tapering, careful attention to effective tapering, and cultural competencies needed to better address inequities in pain management and in opioid use disorder management, all areas of persistent and significant gaps in practice. All of these discussions touched on obviously a wide range of important issues and have helped us set us up for where we are today. And I know there were a few topics yesterday that we touched on briefly due to time constraints. I've mentioned a few of them already. Tapering and the challenges around opioid tapering, inter-provider communication to support effective pain management and OUD management, and then using multimodal strategies for pain management and recognizing that not every approach works for every patient, and some patients need support in getting through that and empathy in getting through that process. So that all brings us to day two. Today, we're going to have two more panel discussions. The first will consider what we can learn from some effective existing provider education initiatives that have been implemented by federal agencies and other stakeholders. Then we'll wrap up the workshop with a broad and forward-looking panel exploring how FDA and other stakeholders can most effectively work towards and work together on improving prescriber and provider education in the future. So just a few more slides to set all of this up. Next, our Statement of Independence. The Margolis Center for Health Policy is part of Duke University, and as such, we deeply honor the tradition of academic independence on behalf of our faculty, scholars, researchers. Neither Duke nor the Margolis Center take partisan positions, but our individual members are free to speak their minds and express their opinions on important issues. And also add that in the conversation today, which is supported through a cooperative agreement with the FDA. This is not a federal advisory committee. We'll not be voting, will not be seeking consensus recommendations. This meeting will be a success if there's a frank and diverse opinion and discussion of the key issues and challenges that we've laid out today. And I'd like to disclose that I'm an independent director on the boards of Alignment Healthcare, Stigma, Johnson & Johnson, and Prognom IQ. I also co-chair the guiding committee for the Healthcare Payment Learning and Action Network. I receive fees for serving as an advisor for Arsenal Capital Partners, Blackstone Life Sciences, and MITRE. And we'll ask our speakers and panelists today to include any relevant disclosures in their remarks as well. Now, just one more slide with some virtual meeting reminders before we get to our first panel. We want to encourage all of you to contribute to the meeting. The Q&A function at the bottom of your Zoom screen is the way to do that. That's a place to enter questions as well as comments on what you're hearing. We and FDA want to hear feedback as well as questions, and many of these we'll try to either bring into the discussion that we have with our panelists, or in some cases, our presenters, panelists, and team may be able to respond directly to the Q&A through the Q&A function as well. We're also recording this meeting. We'll be posting the recordings on the Duke-Margolis website for future reference. And then finally, the scope here is focused on the content of prescriber and provider education related to opioids and pain management. This is not the venue for comments on CDC's guidelines for prescribing opioids for chronic pain. That guideline is open for public comment through the Federal Register. It's a separate process. I know CDC wants to hear from the public on that as well. While we do anticipate that the conversation is going to touch on broader issues such as prescribing guidelines, prescribing limits, other policy issues that may affect care for patients with pain and the use of opioids, we do want to try to keep the conversation relatively focused on prescriber and healthcare provider education efforts. Now, with that context, I'm very pleased to introduce Dr. Marian Hamilton Lopez, who's Senior Director for Biomedical Innovation at the Duke-Margolis Center, and Marian will be the moderator for today's discussions. Marian, thanks so much for joining us today. A very important set of topics ahead for us this afternoon.
All right, thank you so much, Mark. And without further ado, I'd like to introduce the panelists for our first discussion session of the day, which, as Mark mentioned, will highlight some of the important efforts for providing education, training, and resources for healthcare providers. And we'll also focus on what we all can learn about how to effectively deliver education in ways that are targeted and impactful. Joining us for this panel discussion, we have Jan Losby, Branch Chief for the Health Systems and Researchers Branch in the Division of Overdose Prevention at the Centers for Disease Control and Prevention. Catherine Cates-Wessel, CEO of the American Academy of Addiction Psychiatry and Principal Investigator and Project Director of the Providers Clinical Support System. Julianne Hemstreet, Education and Training Program Manager for Academic Detailing at the Veterans Health Administration within the Department of Veteran Affairs. Joanna Katzman, Director of Public Health Initiatives for Project Expansion for Community Healthcare Outcomes, or Project ECHO. And Margot Savoy, Senior Vice President of Education at the American Association of Family Physicians. And now I'm going to ask each of our panelists to give about 5 to 7 minutes of opening comments, and then we'll turn to an open discussion. Jan, we'll start with you.
Great. Thanks so very much, Marian. I really appreciate having the opportunity to be part of this panel. And I have really enjoyed hearing the discussion from day one and look forward to more this afternoon. In our time together, I will highlight our provider education materials and share what we've learned from this process. And before I begin, I'd like to state that I do not have any conflicts of interest to disclose. Next slide, please. The CDC released its guideline in 2016, the Guideline for Prescribing Opioids for Chronic Pain. And its purpose was to provide evidence-based recommendations for patients 18 years and older in outpatient primary care settings. And the principal audience was primary care clinicians, such as family practitioners and internists, including physicians, nurse practitioners, and physician assistants. The guideline was not intended for use in active cancer treatment, palliative care, or end-of-life care. And the guideline is voluntary, and as such, the guideline is not a rule, regulation, or law. And to help encourage uptake, use, and understanding of the guideline, CDC, in collaboration with clinicians at the University of Washington, developed 7 webinars through CDC's clinical outreach and communication activity. And the topics are listed here. And these are free online webinars featuring case-based content, followed by a question and answer portion with the clinician presenters. And the clinicians can receive continuing education credits for each of the webinars. And these were released through several months in 2016. Next slide, please. Following the release of the guideline and following the traditional webinars I just described, we felt it was important to develop a series of interactive training modules, really to emphasize that the guideline cannot replace the relationship between a patient and a clinician, the interaction that includes individual, collaborative patient care, clinical judgment, and decision-making. So the impetus for these modules that you see here was to create content that was more interactive and walked clinicians through hypothetical scenarios with patients. Again, these were free and online training modules. These were standalone and self-paced that include patient scenarios, videos, knowledge checks, tips, and resources, and clinicians could earn continuing education credits. The topics were based on what we were hearing from the field once the guideline was released. So hearing from clinicians and practitioners. So for example, we developed a module on implementing the guideline in clinical practice, a module on supporting a collaborative patient-clinician relationship, as well as a module on emphasizing the role of nurses. And most recently, a module on using PDMP data or prescription drug monitoring program data to help inform decision-making. Next slide, please. I included on this slide many resources for clinicians as well as resources for patients. And in preparing for my time with you today, I was really thinking about what were those key takeaways or lessons learned tied to developing this content, both the traditional webinars as well as the more interactive training modules. So a few takeaways. So keeping the offerings short and keeping the topics very tight and focused. Also ensuring that the content was easily accessible to clinicians so that they can use the resources whenever it best fits their busy schedules. So having them archived if in fact there was a specific training that was offered at a particular day and time, but more often having all of the materials available for clinicians to access them when it best suited their schedules. Continuing to offer continuing medical education and CEs, and also making that process easy. Developing and testing content and materials with clinicians and patients. Ensuring that the content that's shared is evidence-based, and also the peer-to-peer model was really what we heard in terms of feedback was quite effective. So ensuring that we had clinicians providing content for clinicians. And also thinking about this wasn't just a one and done, really making certain that we had ways to connect with clinicians in the field. So continuing to develop content that is responsive to emerging needs. As we heard on day one, the important topic of tapering. So CDC updated and refined its pocket guide tied to tapering, as well as collaborated with HHS, NIH, FDA, CMS, AHRQ, HRSA, and SAMHSA on the HHS guideline for clinicians on appropriate dosage reduction or discontinuation on long-term opioid analgesics. Another example of being attentive to the field was developing quality improvement measures that tied to the 12 recommendation statements contained in the guideline. So we developed the quality improvement measures with close coordination with clinicians in the field, and really in collaboration with clinicians developed a comprehensive implementation guide on quality improvement and care coordination. And lastly, I'll share with you, it was really important to have multiple sort of venues or ways in which to share information. So not just through resources and the trainings I featured, but maintaining a library of fact sheets and videos and posters and pocket guides. We also developed an app so that clinicians could have access to the content of the guideline on their telephones that included the guideline content, as well as motivational interviewing and patient-centered communication skills. And lastly, wish to share, we really thought it was important to tie the guideline and bring it to or within clinical workflow. So we've worked with the National Office of the Health IT Coordinator to ensure that we had clinical decision support tools that were available through EHRs. And so really look forward to the panel discussion, and I'll turn it back over to you, Marian.
All right, thank you so much, Jan. Next, we'll hear from Catherine.
Thank you so much for having me. I really appreciate it. I have no disclosures to make. I am Catherine Cates-Wessel with the American Academy of Addiction Psychiatry. Next slide, please. I'm going to first talk about the provider's clinical support system. It actually started out as the physician clinical support system, then it went to prescriber, and we actually advocated with our coalition to be provider because we feel it's much more than just the prescriber, and we have a multidisciplinary coalition. So our overall mission is to provide resources and support a real framework, if you will, across the spectrum for helping health professionals. So all health professionals, we're very multidisciplinary, are provided training and mentorship at no cost to them. Since 2008, we've trained over 500,000 clinicians through the PCSS training. Most of you will know that the waiver training was a big part of it, but we know it's more than just the waiver. It's prior to the waiver, pre-contemplative, after the waiver, and ongoing. So we have it set up to meet the clinician and their staff where they are. Next slide, please. So our funding is through SAMHSA. We have a large coalition. I've been in the field for over 30 years, and I know it's really about, I call it connecting the dots. Who's doing what? So we have all of medicine involved with us. We have the American Dental Association, American Medical, Pediatrics. We have pain. We have emergency physicians. We have nurses, we have pharmacists, we have social workers. So we wanted to have a large coalition because that's who the providers listen to. They're not going to listen to the addiction psychiatry. Trust me, there's stigma within medicine still, unfortunately, but we wanted them to be the resource to provide the training and education. Next slide, please. And so what types of things do we do? Again, we try to be as flexible as possible to help the clinician to meet their needs. So we have live and recorded webinars. We have mentoring. You can do one stop where you just post a question to a discussion forum that is run by an addiction specialist. We also have pain specialists. We have clinical roundtables. And actually during the pandemic, this became really the go-to. We would have open mics sometimes 5 days a week. So people could just touch base with people just to connect with another clinician or to answer questions. We average 200 people each time on the clinical roundtables, sometimes up to 1,000. We had the PCSS exchange, and that's because we really felt like it's more than just the prescriber that needs to be trained. Their team needs to be on, and not just their clinical team, but the administrative team. So we have a 6 weeks course, and their team can come on, the prescriber can come on when the course that's being taught that week is relevant to their needs. And we average 200 people across the spectrum to participate in that. And how do we help with implementation, setting up systems, overcoming stigma? How can we help them build this system? The next one is PCSS implementation, because honestly, I see this is one of the biggest issues. It is important to train the prescribers, there's no question, but you also have to help them build a system on how to implement this within their clinical practice. So it's really critical to help them walk through what are their barriers to implementation and setting this up into their clinical practice. So we walk them through and help them get whatever support they need to try to help bring their team on board. And we always start every time, it doesn't matter where, with stigma, because the front desk, the CEO, whoever, if they're not on board and feel these people are worthy of treatment, it's not going to work. So the prescriber is important, and so are the other health professionals, but everybody on the team needs to be on board. And then the last one, we have SUD 101, and we have a core curriculum on pain. Melissa Weimer, who was here yesterday, was one of the key authors of that, as is Roger Chow, who is on the CDC prescribing panel. And we have experts that help create these webinars. And the core curriculum on pain is 14 modules, and it walks you through from prevention, treatment, screening, all the way through to complex courses. Everything is free. CE credits are almost for all courses. We have over 800 resources online to make it available for clinicians. Next slide, please. Just to give you an idea of the scope of how many people we've trained, it's fairly large numbers, 247,000 participants in the webinars. The waiver course, I just wanted to give you an idea, since we no longer have the waiver requirement for under 30 patients. Just this year alone, we've trained over 39,000 people, and that's been since the waiver has been taken away. So I just wanted to underscore that while we don't have the requirement, education is really critical. And we often see that when people even take the course when it was required, they want more. And so I think it's really critical to have programs like this where you have ongoing support at various places around their motivation or their level of engagement and willingness to participate, because there's so much around, not so much the prescribing that I hear more often, is that they don't feel comfortable dealing with substance use disorders. They don't feel comfortable with this patient, that this whole disorder is very uncomfortable for them. So they want to have more information and knowledge. And then when you integrate in the prevalence of co-occurring psychiatric disorders and also with pain, it gets complicated. And so sometimes they don't feel equipped to handle that. So having a support system is really critical. And participants in clinical roundtables, over 18,000 in the mentor program. Next slide. So main things are, which you've heard before, stigma, training everyone, health professionals need more education, behavioral health is needed, systems are very, very important, co-occurring, and everybody needs to be trained in all 3 medications. Next slide. Just briefly, the 2 other projects that we've worked on, SUD training is foundational training for all health professionals, reach as a minority, fellowship training that we feel is important to get more represented minorities included in the field. Next slide. And the Opioid Response Network is a program to provide training to anyone in the country. It doesn't matter. It's not just clinicians, it's anyone. Judges are included and so forth. Next slide. And again, everything is free of charge, and you just put in a request and you have a technology specialist respond within 1 business day. Next slide. These are our partners even larger. We represent over 2 million constituents. Next slide. And everybody is our target. I think that's it. Next slide. Just as some examples, and we can provide those of the types of things that people are doing. Next slide. So I think the main thing that I wanted to emphasize is that we all know that stigma is huge. Systems is really important because you can train prescribers as much as you want, but if they don't have a system within to work in, it's very difficult. But I can't emphasize the role of mental health. And I was kind of surprised yesterday, it really wasn't mentioned for the first hour, really. And it really is core to a lot of the problems that we have to deal with, and treating them together with the substance use disorder is really critical. So thank you.
Thank you, Catherine. All right, next we'll hear from Julie.
Hello, thank you for having me on this panel. I'm really excited for this presentation. I'm going to be talking about academic detailing and how the VA has utilized academic detailing and academic detailers to provide education to our providers. I do not have any disclosures, so no worries there. Next slide, please. All right, so today, just going to quickly go over what academic detailing is, because maybe people aren't aware of that, overview some of our resources, and then some of the impact we've had around academic detailing in opioid safety. Next slide. So with information that comes at providers, we like to think of it as a fire hose sometimes. You know, there can be new information happening all the time. And how can we help providers wade through that and figure out how to make the right decision based on the information that's out there? Next slide. So we like to think of our academic detailers, who in the VA, our academic detailers are clinical pharmacists. So those are the folks that we have trained to do this. We like to think of our academic detailers as a lifeboat that is there to help the providers wade through this information. Academic detailing is done individually with providers. So academic detailers will go in and meet with the provider, maybe meet with their team as well, usually do meet with their team, but it's in very small sessions, usually one-on-one, where they're able to really look at the provider's practice, understand what's happening in their practice, how their team works together, how they address certain key issues. And when we've identified a gap in practice, so with opioid safety, lots of different gaps, whether it's treatment of opioid use disorder, doing risk mitigation strategies, providing naloxone, whatever it is, you know, we look to see, well, where are those gaps? Talk to the providers, meet with them one-on-one, learn about their practice, see any objections that they have around that treatment. Many times there are some, whether it's, it can be lack of knowledge, but it also can be system barriers. It can be, you know, just how to integrate it into their practice. So our detailers have really become barrier breakers. You know, how can we work through those barriers and make the system work for the provider and their team so that the veterans have the best healthcare we can provide them. All right, next slide. And so in creating behavior change, it is a very multifaceted approach. It's really looking from leadership down. We need to have leadership on board so that they understand what's happening and what, you know, what goals they have and how we can help the system achieve those. Engaging the whole team, so not just the provider, but the entire team from schedulers, lab, nurses, pharmacists, everyone. We modify the interaction with, so our academic detailers may go in to talk about a topic and it may go somewhere else depending on what's happening in that provider's practice and what concerns they have. We provide resources and then we try to bridge the gap that they may have. And around opioid use disorder, one of the big things, you know, someone just mentioned mental health. Well, we found it was primary care, mental health, pain management, substance use disorder, everyone kind of being on the same page so that when patients went to different places, they were receiving the same information on what would be best to help them and how treatment should go. So we really needed to work through those professional silos to make sure everyone was on the same page. And then looking at whatever system barriers we have and how we can address those. So our academic detailers were involved in all of those different steps. Okay, next slide. And so from our national office, this is what we do to support our academic detailers in their quest to, really helping providers overcome, some of these obstacles. So first, we train our academic detailers in how to do academic detailing and how to utilize that communication skill. We develop educational materials that are around key interventions, key things that come from guidelines or studies or whatever, the information we're trying to get to the provider and the change that we're looking to happen. We create educational materials around those. We also create data tools so that the detailer knows, well, which providers have the greatest opportunity for whatever intervention I'm doing. And then also so that the provider can look at their patients and see which patients really need to be addressed around a certain topic. Our detailers also record their workload so that we know who did they meet with, and then we can see if there was an impact on what happened. And so we do evaluations to see, were our academic detailers successful in creating a behavior change? So did more naloxone go to high-risk patients? More risk mitigation strategies happen? Things of that nature. More patients getting medications for opioid use disorder when they have opioid use disorders. Those type of things. We can evaluate that. All right, next slide, please. So just going to highlight really quickly some of these areas. So training, as I said, we train our academic detailers. They do a basic skills training to learn the initial communication techniques. And then we do advanced skills training all throughout the year so that they can improve their skills, particularly if they're changing topics and doing a new topic. Next slide, please. We also create educational materials for patients and providers. So our academic detailers are able to bring these in, and they will highlight, the key messages we're trying to bring to the provider. So we've done around pain. We have materials around acute and chronic pain. Next slide, please. We also have discussion tools. So this is an example of a discussion tool we have for opioid risks. So it allows the provider to show pictures to a patient and have the patient describe what risks are you most concerned about. So if there's a discussion around, should the patient remain on opioids? Are the opioids causing problems? We utilize some of these tools for that. And then we also have handouts to help the patient. Next slide. So the next slide's just going to go through really quick. So we have some things on opioid tapering to help providers understand when that could be appropriate and how to do it. Next slide, please. Also around direct-to-patient information, so they understand around a particular topic, so also educating the patients. Next slide. We have some things on fentanyl and carfentanil. So I'm going to skip ahead about 3 slides because these are just some of our educational handouts on different topics. And we also have gone into the emergency room to provide information to providers that way. Next slide. So data resources, as I said, we identify providers who may have the greatest opportunity for change through our data resources. Next slide. Also, our detailers track their workloads. This is just an example of, our academic detailers reached out to 76,000. They had over 76,000 visits around opioid safety, OUD, OEND, with 33,000 staff since we started. Next slide. Then we also evaluate things. So this is the last slide I have, and this is just showing one of our evaluations, how academic detailers, when they met with providers, those providers were 3 times more likely to provide naloxone to patients who are at high risk at 1 year and 7 times more likely at 2 years. So we found that academic detailing was definitely successful in this area, and we have many other evaluations that we've looked at. So I'm happy to share more about academic detailing through the panel. Thank you.
Thank you so much. Wonderful. All right, next we'll hear from Joanna.
Thank you, everyone. Thanks for allowing me to participate today. My name is Joanna Katzman. I'm a neurologist and practice pain management at University of New Mexico and direct the UNM Pain Center. And today I'm going to be talking about the Project ECHO Chronic Pain and Opiate Management Program, which has been around since 2008. I don't have any conflicts of interest or disclosures. Next slide. Next slide. And what I'd like to share with you just for our first few slides really is what is Project ECHO, which stands for Extension for Community Healthcare Outcomes. And it really has revolutionized medical education. It started in 2008 as a way for subject matter experts in kind of a more urban centers to reach out to primary care providers and clinicians living in rural communities to connect and to receive best practices training in many different subject matter areas. I started in 2008 to begin to give clinicians best practices, pain management, and opiate use disorder trainings. I had a team of specialists alongside me because Project ECHO is very interdisciplinary by nature. And the hub team, meaning the team of subject matter experts, really the model of Project ECHO is to create an interdisciplinary team of experts to provide that training. So I myself, a chronic pain specialist, and I had an addiction specialist with me, a psychiatrist, a primary care provider with training in myofascial expertise, also a physical therapist and a pharmacist. And we trained primary care providers who were living in rural and underserved regions to provide kind of best practices care in chronic pain and opiate management. And then later on, we helped to train the VA and the Indian Health Service and the Department of Defense. And more recently, we've been training U.S. Public Health Service Commission Corps officers, and now many academic medical centers all over the country, and now in 85 countries are practicing Project ECHO chronic pain and opiate management programs. But the 4-point ECHO model, next slide, if you will, the 4-point ECHO model really combines best practices and evidence-based didactics with case-based learning. We know that adults work better, adults learn better when they hear cases. And Project ECHO prides itself on hearing real de-identified cases from clinicians in the field. And so different from a webinar, different from just a regular didactic that you might hear over Zoom, Project ECHO almost always has real cases presented to the hub team at every session. And through kind of iterative learning over and over, adults really learn how to kind of master the complexity of these cases. We are always evaluating what we're doing and hoping to do better, and we use this technology to spread the knowledge. Next slide. So different from traditional telemedicine, where there's a patient at the other end of the Zoom technology platform. Back in 2003, when ECHO started, it was not Zoom, it was Polycom. Traditional telemedicine is still, as you know, essential. And when the pandemic hit, we all jumped onto kind of the Zoom platform to see our patients. But Project ECHO really prides itself on really being capacity building and really being able to scale up and be replicable. And so what happens is you have an expert, diverse hub team who's able to deliver best practices trainings to many, many clinicians at the same time, who are then able to share what they've learned to their colleagues at their clinic and their kind of institution, who can then all diffuse that knowledge to their patients. So you can see the top of the slide here, the diffusion of knowledge is much greater than that traditional one-to-one traditional medicine, but very powerful model. Next slide. So we call it a hub and spoke model for Project ECHO. The hub team is this interdisciplinary hub team, which allows us to model the participants who are in the spokes, who are in the community. We know that the participants who attend are a combination of physicians, nurse practitioners, PAs, pharmacists, community health workers. And so our hub team really tries to model that interprofessional nature of the participants in the field. Next slide. So I just want to mention that Project ECHO is now in all 50 states, and the slide is a little dated. We're in over 85 countries now. Next slide. This is an example pre-pandemic of when we would all join our weekly ECHO pain and opiate sessions in a room here. This is at the ECHO Institute in Albuquerque. There's over 50 academic medical centers in the United States that now have ECHO pain and opiate management hubs. We have hubs for medication overuse disorder, ECHOs as well. Next slide. So the tools for ECHO pain and opiate management I mentioned include best practices didactics, case-based learning. We frequently offer 2-day trainings and hands-on tools. We offer no-cost CME, and we provide kind of ongoing curriculum development, meaning we change the curriculum usually every year based on new things that are happening nationally, based on, let's say, the National Academy of Medicine report, based on the new CDC guidelines. So we're constantly pivoting and changing based on new national inputs, and also by provider, by what the providers tell us that they want to hear from us. Next slide. You can go on to the next slide too. I just want to let you know that we're constantly meeting the mandates of our rural clinicians. We've created many different assessment tools. We try to keep, when we hear patient cases, we try to really follow a very methodical, deliberate way to hear cases so that we can make it as bi-directional and all teach, all learn as possible, so that the participants are always feeling as though they are part of the equation and learn most optimally. Next slide. I'd like to just show you a typical 12-month weekly ECHO session. We talk about the opioid overdose epidemic, a public health crisis. We go over chronic pain basics. We talk about addiction. We then, because we have the Zoom platform, we're able to actually showcase and teach on hands-on skills, whether it's the myofascial exam, trigger point injections, acupuncture, taping, a kinesiological taping, the physical therapy exam, the neurological exam. We talk about different cultural needs like Native American health and wellness. We talk about chronic pain and substance use disorders across the lifespan. And someone mentioned previously, I think it was Catherine, perhaps, the real need to also incorporate mental health as we're talking about both chronic pain and substance use disorders, which we do, including suicidality when we're talking about patients with chronic pain and substance use disorder. Next slide. We also very much talk about the pharmacotherapy for patients with chronic pain and substance use disorder. We talk about palliative care. We talk about naloxone co-prescribing. We talk about integrative pain management and emerging treatments. Next slide. This is just a map of all the ECHO hubs worldwide that are continuing to grow and are now in over 85 countries. Next slide. I just wanted to show you briefly, we helped the Navy and the Army launch many hundreds of opioid ECHO hubs and spokes across the continent and out of the continent from 2011 to 2018. And we studied the clinicians and their patients who participated in ECHO versus those who did not participate in ECHO. Next slide. And these are the places that the Army and Navy pain management ECHO clinics are held in about half of the states, in Western Europe, in Korea, other parts of Asia, as well as Hawaii. And next slide. And what we found doing a very robust near patient level study with high data sharing agreements was that there was a significant decrease in new opiates that were prescribed. If opiates were prescribed, there was a much smaller amount of morphine milligrams equivalent prescribed, and a much decreased co-prescribing of opiates and benzodiazepines for the clinicians who participated in echo pain as compared to those who did not. Next slide. I also finally wanted to tell you we're just finishing up with the CDC, educating U.S. Public Health Service Commission Corps officer, a very diverse group of clinicians, pharmacists, physical therapists, but primarily physicians, nurse practitioners, PAs, working in all areas of the federal government, including the FDA, I should say. We had a 16-week curriculum based on kind of the latest CDC guidelines, based on the fact that we wanted to address the four main public health crises of chronic pain, substance use disorder, mental health, and suicide, that we wanted to talk about opiate and benzodiazepine tapering, as well as non-pharmacologic strategies. We use simulated cases. It's not published yet, so I don't have the report, but we got really excellent self-efficacy and knowledge scores from the participants. These participants also took part in buprenorphine half and half trainings, participated in focus groups, and really felt as though this training was quite effective. Next slide. This was a simulated case that they every week they also participated in a simulated case that corresponded to the topic. Next slide. This was a HRSA shared services model that was part of one of the Echo Institute programs that we held a couple of years ago. Next slide. And this is one of the larger HRSA national opioid programs as well, with many learners. Next slide. And then finally, several references for you all. Thank you.
Thank you, Joanna. Finally, we'll hear from Margot.
So thank you everyone for the opportunity to be here with you all today. I didn't make any slides because honestly, I just didn't think that hard about it. I really just wanted to talk to you about the American Academy of Family Physicians experience. And I think we can do that this way. So I do serve as the AAFP liaison on the education part of the NAM Opiate Collaborative, but I don't have any financial disclosures. The American Academy of Family Physicians is a proud partner on that Opiate Collaborative, and also they work really closely with SAMHSA, the FDA, and a lot of other partners. So we really like the idea that we get to partner and collaborate to assist family physicians to deliver the best possible care they can to the communities they serve. So to set the stage, I actually think it really helps to sort of briefly frame the experience of what I like to call the opiate backlash, although I don't know that everybody calls it that, in our society's response, because I think it had a really big impact on physician engagement with opiate education. As a practicing family physician, I can tell you that some of the things that happened shook me to my core and made it very challenging initially for me to be open to receiving education around opiates and how to manage pain management or substance use disorder in my own practice. And so I think it's valuable to sort of set maybe the stage a little bit. So the Academy has actually been providing our members with guidance and feedback about how to manage pain and options for addressing substance abuse since long before this was a national concern about addiction and death. The challenge is that for many of our members, that experience of going from being blamed for not treating your patient's pain adequately, and in some ways demonized for holding back life-changing medications that can make your patient feel better and be more active, to shifting to being blamed as being the reason why patients were having an opiate epidemic and the reason why people were dying in communities was startling. It was very challenging to imagine that you were trying to do something to help patients and ultimately you ended up harming patients, and that somehow you were the lever, the person who actually flipped the switch that made it possible for that to happen. For many people, they felt a lot of guilt around causing harm in the patients that they were caring for. And they really had intended to simply relieve the pain that their patients were seeking. There was also some early framing in the pandemic that really painted patients, that ones that you sort of knew and loved, the people you'd been caring for a long period of time, as essentially being users. They were coming in and they were seeking drugs, and they were essentially making you complicit in this sort of war on drugs thing. And they were putting you almost in the role of being the drug dealer, and you didn't even know. And so you started to have what I will call a space of mistrust. So I think there's always an interesting dynamic about trust between physicians and patients. But in this particular case, this was a situation where clinicians started to look at patients with a significant amount of distrust. And that got exacerbated by how we chose to respond as a society, because for many frontline physicians, they found themselves suddenly under a microscope. So people are now looking at your practicing behaviors, they're looking at the work that you're doing, they're looking at the patients you're caring for, and asking a lot of questions, which in some cases were very appropriate and valuable questions, but for others really felt to be very heavy-handed and very disconcerting. And the solution for many frontline physicians was to simply discontinue opiate prescribing in all circumstances and remove themselves from that sort of state of constant surveillance, or feeling like their license and or their livelihood, or in even some cases, their freedom could be put into jeopardy if you could actually be arrested for what people perceive to be inappropriate prescribing behavior, even if from your perspective, you felt like you were following medical guidelines. From a practical perspective, there was a lot of stigma that came through, where no one wanted to be known as the pain doctor in their community. No one wanted to be known as the doctor that gives out quote unquote pills. And so at the end of the day, you sort of found yourself in this situation where you created a gap that left some patients untreated and some physicians feeling quite demonized. At the same time that all of this was happening for primary care physicians, your emergency room and surgeons felt like, we're not going to contribute to this either, and drastically cut back the amount of prescriptions that they were providing, which in many cases was rewarded and prided and everyone is very excited about. The challenge was that their solution was to send all of those patients back to their primary care physician to manage their ongoing chronic pain, because we lack people who can actually manage primary care pain outside of that setting in most communities in America. And so now you've got people who are no longer prescribing, you've got people who don't want to be the ones prescribing, you've got patients caught in the middle. It became a really uncomfortable and not great place for anyone to be experiencing. And so how do you then address education? How do you engage people to want to be interested in having a conversation about a space that they don't really want to go back into, that comes with its own challenges and is sort of fraught with angry patients, angry specialists, angry pharmacists, everyone's sort of feeling like they were in a bad situation. And so what we found as a medical society was that education was probably the place that we could be helpful, and maybe we could help people move past and through the things they're talking about. But we quickly ran into the idea that state-based mandates actually drove most of the education that physicians were willing to take. And the reason was because it was the only way they could get their license back. The challenge for us was that often it didn't include the state clinicians to be able to sort of add the feedback or the color of what needed to be given. So for many, the education actually just felt like a checkbox, a thing to do just so that you get your license and move on, because the content that was provided was entirely too basic, and it did not at all look like the complex patient situations that were showing up multiple times a day in your practice. And so as a medical society, we figured that's actually where we can step in. So how can we hear what our clinicians are needing and shift in a way that we can make that a possibility for them? And so we leaned into what we're sort of known for at the American Academy of Family Physicians around our education. We very much pride ourselves on being evidence-based, being patient-centered, being practical, being team-based, so that it's not just the physician, but the team that they're leading that's actually doing the education and the training, having longitudinal experiences where people can implement things and then see how that's working over time and really use some of their practice improvement skills to create systems that support them. And then it's agile, where you can be flexible, not only in how you're learning, but in what you're learning and how you can apply it. So we started by having an ongoing dialogue with our members, a conversation about what they need, what they see needing, what they see coming down the pike. And then we just sort of tried to build what they need and or partner with people to make sure we got what they need. So for example, our pain management and substance use disorder work goes together, because we realize that for most practicing physicians, they're going to find that shows up to them oftentimes in the same patient, and knowing what to do and how to manage those people was critically important. We've been very intentional about providing that didactic knowledge that they need. However, we don't need to recreate the wheel. So if other people have already created that content, that leveraging and pointing people to that content is much more reasonable and effective. However, what we can do is look at where that didactic information could use a next layer. So the layer where you start figuring out how to help the physician create a sustainable system within their practice, thinking about pulling things like practice improvement, team-based care. If you think about sort of the idea about how you can be intentional about your patient-centeredness. So thinking about how to not exacerbate your trauma-informed care that you work so hard on, or the stigma and inclusion work that you work so hard on, by now sort of applying new levels of stigma and lack of inclusion to now your substance use disorder patients who are presenting to you. And so finding a way to help people work through some of those more complicated and delicate issues. One area that I think is critically important, and it's why I started by talking about some of that framing that happened in the beginning, is that I think some of the education is around helping family physicians and primary care clinicians in general move past their fear of opiate prescribing, their fear of patients with substance use disorder, and actually feel like they have some self-efficacy, that they actually can manage the patient with chronic pain. They actually can manage the patient who develops a substance use disorder, and that that's not problematic. They're not going to lose their license. We're not going to throw them all in jail. It's not demonized. There's no stigma, that we actually do just want patients to get the proper care at the time they need it in the best way they know how. And so having education that helps people move through that space, but also feel like they have the skills and the talents to be able to do that, is critically important. So for us, we do that with a variety of different mechanisms. We know that we need the didactic information that we mentioned before. You need hands-on opportunities to actually practice some of the really sensitive conversations in a safe space before you have to deliver that in a patient situation. You also need the opportunity to have things that are both virtual and in person. So you could have courses that occur in both spaces. We provide practice-based tools. I mean, in our space, everyone seems to love a digital toolkit. Oftentimes these things now look more like a collection of resources where we can point people to other tools that exist or develop the gaps that really we show up. We do offer waiver training alongside with our other clinical topics. So while we do have a substance use course, we also like to integrate our substance use and our pain management content into our other courses, so that it just loses the stigma, because it's just one more topic on the list of topics that a family physician should know to take care of the practice that they're caring for. We also open up opportunities for them to work in these practice-based teams and in interprofessional teams. I love that I get to go right after Project Echo, because we actually love the Project Echo model, and we do use that as one format for how we deliver some of our care. And then we're also intentional about providing all of these sorts of training opportunities, not just for practicing physicians, but also for our residency training spaces, because we need for the future clinicians to also know how to do this as they move forward. We don't want them coming out of residency training, having experiences that leave them unprepared to step into this space as they start their new career. We know that this work is challenging, but we think that allowing learners to have some individualizability, so the options to be able to dive deeper where they need more help and to pull back and maybe do something different where they don't, is a really critical part of this adult learning applied to this space. And so we do wish that some of the state mandated work might be a little more flexible and provide people the opportunity to pick the part that they actually need and really help them dig deeper, so they could have some buy-in to actually making sustainable changes when they're done the training. And from a practical perspective, the Academy is just really excited to partner with others to do this work. And we look forward and are committed to doing this work both now and in the future. So thank you so much. I'm looking forward to the panel conversation.
Great, thank you so very much. So we have on the next slide a few questions to get us started. But what I'd really like to start with is, yesterday we talked about a number of professional gaps, and that was cultural competency. It's having inter-provider communication or interdisciplinary approaches. And, so I'd love to hear from those of you who could expand a little bit more on your opening remarks about how these initiatives specifically are addressing some of those professional gaps that we identified. So Catherine, can we start with you, please?
Sure. Thank you. I think in particular, we've kind of worked on this on the interdisciplinary approach with the provider's clinical support system by setting up a panel for our accreditation. So we have IPCE, so we can provide accreditation across all disciplines. But so we have a representative from each of the various disciplines in healthcare, and they review each resource that comes out before it's presented to make sure it's appropriate and which disciplines would be most applicable to. But what we found out more recently was, as we've been doing some more trainings through the Opioid Response Network, we've been working with the Native American community, the indigenous communities, and we had a presentation come in around that. And so it was brought to our attention that sometimes the information coming in for ACCME doesn't align with what the indigenous people and the cultural aspects of what you're seeing. Evidence-based practices, there's not a lot of evidence-based practice around indigenous communities. So one of the things that we learned is to have a representation from various disciplines to participate in the IPCE review. So from the academic and review of evidence, but also from the cultural perspectives and going back into the community to provide the resources. So that was something to me that was very new, but it was very enlightening to say for cultural perspectives. We also have a Black African-American communities, sexual and gender diversity community as well. And so we're going to have representation across all of those various communities to make sure not only looking at what's evidence-based, what's scientifically sound, but also culturally appropriate. And so I think that for me was a real recent lesson learned of things that we need to keep in mind when we think about what the expectation is for meeting guidelines around ACCME, but also cultural approaches to it as well. So I think that was something that we found more recently that was very beneficial.
Excellent. Thank you for those examples. Can others join in on and kind of how your particular initiatives are really focused in on the professional gaps that we identified yesterday? Jan?
Yeah, I would just add, and I think it was mentioned yesterday, but it was really an important point, and wish to comment on looking at sort of the opportunities for engagements. Not thinking about clinicians as a one body, but also like where are those opportunities? So when individuals are in medical school, or they're in residency, or they're early on in their practice, or they're later on in their practice. So really understanding what are those particular needs depending upon the touch point along that continuum. So I think as we consider what are those gaps, there may be specific gaps depending upon where we are looking along the continuum.
Excellent point. And Joanna.
Sure. I would just add everything I think that Catherine said was right on. I would just say that, the Project ECHO program is definitely ACCME kind of certified to be interprofessional, and our team also looks at, how interprofessional our team is, and is always kind of looking at making sure that we're addressing the needs of those in the community, for which we serve, and that we're making sure that we're culturally competent as well. And we provide different ECHO programs for different people. So we've had an Indian Health Service ECHO for many years, providing an ECHO for clinicians working in IHS areas, which has been very kind of enlightening and let us know kind of what the needs of communities in Indian land has been. And so that's just been something that's been helpful. And then something that has allowed us, I think, to kind of stay afloat for many years is just constantly kind of revamping the curriculum to stay abreast with the changes and not get behind.
Well, yes, Margot.
One of the things that I think is really important to think about when you talk about interprofessional is that sometimes it's not even just the professionals who would need a CME type credit. A lot of times I've found in practices that some of the biggest stigma challenges come from your medical assistants or your front desk clerks who just sort of set up a situation that doesn't make it comfortable or feel safe for the patient to present or share. And oftentimes I've found that when you dig a little deeper as a practice, it turns out it's because they have their own traumas and their own experiences that you haven't necessarily addressed as a practice. And so I do think that there's a space for definitely including the CME. And I totally think it makes sense to think about, whenever there's an opportunity, getting your nursing credit and your other credits. But I don't want us to forget that there are other professionals who are in those practices that are both affected by the experience of caring for people in this space, but also have that own life experience that sometimes gets triggered by having patients in that space. And I really think we do everyone a service when we help them sort of work through that also, because I think it changes the tenor of the practice and often the tenor of the visits, since some of the most contentious spaces happen in those places. So calling for refills, needing to have your urine drug screen done, those sorts of things happen in those spaces. Often the physician isn't anywhere near that space at all. And so can't even adjust it if you wanted to sort of correct it because you wouldn't have been there to hear it. And so I just sort of like to put in a plug for those groups also, because I think sometimes that's really missed in some of the interprofessional training work.
Absolutely. And I'm going to turn to Catherine, who I saw your hand was raised, and then to Julie. But just as a follow on to that point, Margot, and to the earlier presentation about addressing stigma, and you all have mentioned these collaboratives and that have brought in so many different professional, nurses and frontline and, the clinicians themselves and the pharmacists. How do those on the line who are trying to think also about implementing such a program even begin to think, how do you bring so many different partners together who might speak a different, for lack of a better term, like kind of a day-to-day language about how they practice care? How do you start those conversations? So Catherine, turn to you.
Yeah, I just want to build on what Margot said, who's actually the American Academy of Family Physicians. So it's one of our partners and I love working with them. So thank you so much for working in that area. I think it's really, really important. And I mentioned this earlier is that like the front desk, when they welcome people, that is a huge opportunity, but quite often that can be the one thing that turns a patient from wanting to come back, because a person can say, oh, you're here for buprenorphine. And then immediately that person feels shame. And so immediately people will say, well, you can't keep them engaged. They don't want to come back. Well, would you want to come back if somebody made you feel even worse than you already feel? So I think, or you're in the back and you have a phlebotomist taking your blood or something, and they see the track marks or something. Oh, you're one of them. And we've had people say that even staff that have worked in treatment centers say, I was on methadone. None of my clinic, my partners knew about it. I went in to give birth and I told them I was on methadone. No one would touch me. And people were like, what? And so immediately people realize, oh, she's one of us. It's not one of those people. So I think she's absolutely right that we often focus so much on just the prescriber or the health professional, but everybody on the team. And so we often do SUD 101, and we have a very basic layman's term training that we provide to the entire staff, from the front desk to the CEO. CFO sometimes can be one of the biggest challenges. Clinicians want to do it and they want to be on board, but if the CEO says it's not worthy and, oh, it's going to take a lot of time, it's going to cost us money, we do a lot of SUD 101. You can't get anything else done with the rest of the team if they're not on board and they don't feel that these people are worthy and necessary to come in, because otherwise they'll say, well, can we put them in a different waiting room, or can you have them come on a different day? So all kinds of things, because they're not really sick people, they just want to be high. So I think that until we get past those things, you're not really going to change the way people are treated, and you're not going to have providers that want to do it because they have to fight with their own staff in their own the community to try to move it forward. So I think it's really critical.
Great, thank you so much. Julie?
I absolutely agree with everything that's been said. I mean, addressing stigma is huge. We've brought in some folks to talk about that with our staff, and definitely hitting all aspects of the staff, not just providers, but everyone involved, every touch point that patients have. A really great speaker that we had, Stephen Samra, he's a veteran who also went through having opioid use disorder and shares his experience with that. And those shared experiences can be so helpful, learning from people through what they've experienced themselves. We do a thing called VIP Post, which is a pain meeting that every location has in the VA. And so we do some national talks and some local talks amongst the facility with all the providers, staff, as many people that can join, and we try to address stigma, try to address all of those things in those meetings, and bringing patients actually will come in and share their experiences during those meetings. So those have been really helpful when we've been able to do that. We also in our educational materials really try to address stigma. And then another area we're trying to really get into is, while we address all of this, we also we want to address everyone as an individual and where they're coming from. So we know that for pain, women are different than men, and how they present and what they present with and things like that. And so we need to address people differently depending on their background, culture. Culture plays a big part in this. And then even, going to the very beginning of, how do you even want to be referred to? What is your pronoun? What is all that? We're really trying to talk to our providers about that so that they really can help embrace the patient where they're at, in terms of who they are, where they're coming from with their pain, what is causing, all of those things. So we're really trying to go back and make sure that we address and from all aspects of the team.
Thank you, Julie. That's a great point. And from one of the comments that we've received online, multimodal doesn't, these options don't work for everyone. And so how, I'd love to hear examples from your initiatives about how do you incorporate patient experiences, preferences, and even their external situations, like the based on their own clinical practices or that they're experiencing or reimbursement. They're not going to all be in the same situation. So how do your initiatives address that through education?
I'm happy to talk about this again too, just a little bit. Through the VA, I mean, the reimbursement is not part of our issue, so that's very, very helpful. We don't have to deal with any of that. But what VA's really been trying to do and has made a lot of efforts around is doing that multimodal approach. So it's not just the provider, a primary care provider on an island by themselves, but what other things can we incorporate? And I think one of our most successful things has been whole health. So we've had a whole health initiative where there are whole health coaches, where patients can be assigned a coach, and that coach helps them. And the number one question is, what is most important to you? What do you want to achieve? What are your personal health goals? What do you feel is the thing that makes it, life most worthwhile, and how do you want to get to that point? And then they point them in the direction of what are things that can help them, what are things that are interested, that they find interesting. It can be acupuncture, Tai Chi, cognitive behavioral therapy, whatever it is. And they have so many different programs now that patients can get involved in once they get connected. And so it's really an exciting program that we're really trying to get more and more people involved in, because they've, patients who have done it have had such dramatic results, because it brings it back to them. What is most important to them? What do they want to achieve?
Great. Thank you, Julie. Margot?
So we've had experience being able to use people with lived experiences in a lot of different spaces. I find opiate use disorder and pain to be difficult ones to actually recruit patients for, partly because some people don't want everyone to know their business, and not everyone is necessarily connected to a speakers bureau, so they don't always feel comfortable getting up in front of a group, and physicians in general just feel intimidating. So even if they're not necessarily there for any reason other than to learn from you, it feels a bit scary for them. And so as you're having that conversation, it just doesn't feel like a safe space for them to tell their story. One way that we have seen be beneficial, which is interesting, because I don't know that we would have figured it out quite so quickly if it were not for COVID. But sometimes these opportunities where you're not actually in this space with the other people so that you could actually talk, but you're in the safety of your own home or your own location, or you have the opportunity to make a video where you can talk about your story, but you have some control over the person you're talking to, so that like I'm talking to you, but I'm only talking to you. So like I can go back and edit it if I don't feel comfortable as the patient with the way I said it, or what I said, or what I shared, or however, how it's going. I have some control over that, as opposed to I just put you on a stage and expect you to suddenly perform. I think that those are opportunities that I don't know that they really existed before. People didn't really have access to the cameras and the things that we all have now, which is a little bit helpful. So I do think that's helpful. But I actually think normalizing including patient experience across the board will make it much easier for these types of conversations, which gets a little more sensitive, because I suspect that for many people, it is not unlike when you try to find patients to come and speak about their experience with depression, or their experience with feeling like they've discriminated against in the healthcare system, like all of these sort of quote unquote touchy spaces, like the ones where you're basically having to tell the doctors or the clinicians that you're talking to that they did bad things. And that's a really scary place to be in from the patient side, because you're not entirely sure that like they don't all have friends with the doctors who take care of you, and that it might somehow come back to harm you. And so I think it's a great space to be in. I think we have to be careful and protect the people who we invite to do that work with us. But I do think that it's a challenge. Like I have not found it to be particularly easy to always find someone who felt comfortable doing that work, even though they agreed with the concept or the idea.
Great, thank you. Catherine?
So there are two things that we're working on, and one, Margot, might be a good resource for you and others as well. The Opioid Response Network is set up to be locally driven. So it's supposed to respond to needs at the community level. And we have prevention, treatment, and recovery and beyond consultants in every state and territory in the entire country. Anybody that has any kind of request around opioids related, pain, substance use disorder. We have consultants from those different areas. So if you were interested in having someone from the recovery community come in and give a talk or be participating in education, we would pay for that person to come, and we vetted all those people. So we have lots and lots of consultants we've gone through and trained. So if you wanted somebody to do that, we could provide that at no cost. So that's one way to respond to any of your needs that you have around this, to get the type of resource or expertise or experience that you need to help support your training with the materials and so forth. The other thing that we're doing, I know is really important, is on the provider's clinical support system, we're actually working with states. And we go in and we meet up with the state and the community. We do the implementation where we work hand in hand with one clinical site, and we walk them through, hold their hand basically with a multidisciplinary team with implementation scientists. What are your needs? Do a needs assessment. What are your barriers? And then we help build their system as we go along, which is really important. Oh, you need access to behavioral health. Okay, let's find that. Oh, you need more people to get trained. Let's do that. Oh, you need Stigma 101 with all your staff, all those things to kind of help them work together. And what are your state policies? Because a lot of times we're working with Alabama right now. They have huge, state level issues that make it even more cumbersome and complicated. We're also working with the state of Alabama on using standardized patients, or actors, if you will, and to give people an opportunity to practice. Ask them those awkward questions. Get a sense of if this is appropriate, or I'm not sure, because people feel very uncomfortable. Providers feel like they're being judgmental and that they're getting into somebody's private business when it's about health. And we keep trying to explain to them, this is relating to your health. Let's just focus on that. But they feel differently when you're talking about substances or something that could be illegal or inappropriate. So getting the providers and the prescribers and the whole healthcare team more comfortable with having those awkward discussions. What do you do if there's still opioids in their urine? Okay, you're just going to kick them out? No, you're going to have a discussion about it. That's a red flag for re-examining the treatment protocol, looking at their medication. So I think part of that is really important. The history behind the substance use field has been about anonymity. You don't want people to know, but we really need to integrate it, to medicalize it, so people understand it is a medical disorder. And as clinicians, we need to understand and know how to deal with this. So we need to be able to feel comfortable with having these discussions. So I think those practical applications is really important as well.
And then thank you, Catherine, taking that thread, Jan, is this similar to kind of your own experience with working with states and trying to take something like your national guidelines of 2016 and having them meet the needs of states and localities? Just wondering kind of what feedback that you get as far as kind of what are the unique challenges that they are facing that we can try to respond to from more of a national level.
Yes, thanks, Marian, for that question. I mean, I was reflecting on, in terms of how to help and support implementation of the guidelines. So we launched a quality improvement collaborative at the health system level. So similar to what Catherine was describing, really working side by side with clinicians in a practice to understand what is the top priority or the area of the concern that they are grappling with, and then working with them alongside to identify, is it the peer-to-peer clinician education aspect of it, or is it more the sort of the front of house component that people have already spoke on? So at the system level, it's what we have found to be most productive is having a hands-on, not a one-size-fits-all, but really, we have the evidence, but then in terms of implementation and understanding how to help support what's working at the practice level is to make certain that it's this conversation and collaboration to understand what is it that is of most use for that particular practice. And then, Marian, you were mentioning at the state level. So we have the good fortune of working with partners in the field of public health partners at both the state, the county, and the local level. And through their collaboration networks, it's really an opportunity to help advance, whether it's linkage to care opportunities. So thinking about the guideline itself in terms of prescribing, but there are all sorts of opportunities within the public health space to help ensure that patients have access to the care that they are intending to seek. And so really developing those linkage to care opportunities as well.
Excellent, thank you. So a follow-up question for Joanna. You mentioned how you're all 50 states and different countries, and is there a kind of a secret sauce? Like how do we scale a program such as this? And, I think it's great that, some of you know one another, have had opportunities to work together, but is there a way for kind of lessons learned to be shared kind of across these various different programs that are all touching so many communities and within states, within different local communities, but also now internationally? So how do we scale? And then also, how do we share the information as we're doing so?
I don't know. Thanks, Marian, for that question. It sounds like a loaded question, and I don't know the answer or have the secret sauce, but
It's not meant to be loaded.
no, it's not loaded, but I don't have the secret sauce for sure. I do know that it really has, taken off. I think because it really is, not difficult to replicate. Most academic centers really have found that kind of building a echo within their university has been beneficial for them. It doesn't take a lot of dollars. And if they have a pain program or a substance use program, they've been able to kind of have the same faculty members actually participate in that echo, and then use that echo to train not only their fellows, their residents, their medical students, but also the clinicians in their community in their state. And then also, as a added benefit, be able to use that network to be able to triage patients to see whether or not that patient needs to come into the pain clinic any earlier or the substance use clinic any earlier. So it's been used also as a way to make sure that patients are getting the right level of care. We talk about echo being, making sure patients are seeing at the right, getting the right knowledge, getting the clinicians the right knowledge at the right time, but also the patients getting the right knowledge and the right care at the right time. So, like, for instance, if I'm running an echo in Albuquerque and I'm talking to a patient in the Navajo, talking to a clinician whose patient is in the Navajo Nation, and we're discussing that patient on a Wednesday afternoon, and that patient seems like they're in a lot of distress, according to his or her clinician, I will tell that clinician, let's get that patient down to UNM tomorrow, as opposed to that patient being, referred to the pain clinic and have a 3-month wait and, not being triaged appropriately. So it serves that purpose too. And I feel like other academic medical centers have also seen the benefit. Because of our knowledge all being kind of democratized and demonopolized, I think that's why ECHO has taken off, because when there's a curriculum that's been built, let's say in 2021, and it's felt like it's evidence-based with best practices and the references are good, all the other ECHOs can use that curriculum and edit it and modify it to their own region to make it culturally appropriate for their own region. So they can take parts of it and they can, and then they can add parts of it that are maybe more, beneficial for their own region, that are culturally sensitive, perhaps. So that's why I think it has been scalable so quickly.
Thank you, Joanna.
Yeah.
Margot?
One of the other things, so I absolutely agree. I think learning communities takes almost anything. It makes it just easier. So whether it's regional or national or international, I mean, you learn so much from your peers, and a lot of times they don't even know they're teaching you things because they're just talking about what they do. But what they do naturally may not be what you do naturally. So you just pick up and learn things. So I love the idea of learning collaborators in general. The other space that I think really for me has been exponential, and I think it works well for the academy. We hang out a lot with peers in that sort of academy level space, so that things like the NAM collaborative, when you're sort of just in the room with a whole bunch of people that you might not have otherwise known, and then next thing you know, you now know them. So when you go to have a thought about a thing, you know exactly who to call or know exactly how to connect. I think those things become exponentially helpful because you just sort of start growing, and then that group grows, and then the group that they know grows. The next thing you know, you're doing things. Aligned with that is having a single place to go to find things, so that our members, for example, will come to our website first, and that's great, but I don't necessarily need to always be the one to have created the things that we're linking people to. But it is often really challenging to find the things that everyone else has done. So like you figure it out on the fly later somewhere else. And so whenever we have opportunities to collect and sort of curate the things that are really great that we know are just wonderful, having places to showcase those things and having a central digital place to access them has been critically important. Because while I think toolkits, I mean, I have joke about them because people ask about them all the time, but people never want to actually use the toolkit when you make it. But what I have found is that people will Google, I need a screening tool for blah, blah, blah. And if you've done a really great job creating your tools and you put them in a place that's searchable and easy to find, they will rise to the top and people will use them because they'll be able to locate them and find what they need or find what they need to adapt to get to what they want. And so if we have those opportunities, I think a lot of things that people are doing that seem like maybe it just worked for their system actually would be incredibly scalable at other systems. You just wouldn't even know who to begin to talk to. So if you just had a place where you could put it out there, people could then seek what they need, as opposed to you having to know who exactly to push that information out to.
Great points. And Catherine?
And I think that's what the provider's clinical support system, that's the basis of that. And it's to be one-stop shopping. It's not to say that we or AAAP is the place or we the people. It really is to bring in the American Academy of Family Physicians, emergency physicians, all these various partners and say, what do you feel is needed? And so we want to be a one-stop shopping. And I think we are in a lot of ways. A lot of people say they go to CDC, they go to NIDA, they go to SAMHSA, they go to PCSS because it's a collective thing. I think the other thing that's really, really important, so we work really, really hard is not to be duplicative, not to compete. We're not here to like ignore what other people are doing. We really aren't. We really want to bring the best to the forefront and make it readily available and easy, no cost and so forth. The other thing that we realized on PCSS, it was meant to be for practicing providers. We know the students don't have the stigma that the practicing folks do. The students are the ones who are bringing up the rest of the world about why aren't we treating these patients? Why aren't I getting educated about this? And they're the ones that are pushing this whole idea or the movement to get this to be incorporated into their training, which is critical. But like Jan said earlier, it's got to be across the continuum, because if you go in as a student and you get trained, and then you go into residency and your proctor or your supervisor is not supported, then you kind of lose it and you don't do it. So it really has to be across the board. So we're now setting up a multidisciplinary repository for trainees and faculty for the students, so they can come in and pick and choose the training materials that they want, and a mentoring system to help the faculty, because a lot of them are being pushed to do this training, but they don't really have any experience in that area. So we really want to try to help fix what the medical education program missed years ago by not having it integrated in to be part of a vital sign, if you will, or part of general wellness taking, is to be able to ask those questions and how to incorporate it. So one-stop shopping, I think, is critical. The other thing I think that's really, really necessary is networking and collaboration. I think that's been the key for so many of us and we came up with guiding principles, because prevention and recovery, they come in from a different perspective. And I've always been in the treatment working with physicians, but you have to value each perspective. And particularly with this disease, it goes across so many different areas and different perspectives. So we set up guiding principles that we all have to agree on. Every partner organization, every consultant, anybody that works on it has to go through these guiding principles to agree that being on a medication means you're still in recovery, that you should be treated as if you're in treatment and not denied treatment. That was a tough one at first with the recovery community, but now they agree to that. It's a brain disease. People relapse. That's part of it. Everybody had to agree. So once, it's like marketing. It's like not just do it or whatever. If everybody's talking the same language and selling the same things, we're more likely for the general public, which is another big piece none of us have really talked about, is educating the public and the patient, because often they're the ones that are getting pressure from their family members not to participate in treatment, particularly with medications, because it's a drug for a drug, or a misnomer of how it, and why it is. So I think really as a society, not only the medical community, but the general population, to understand how the brain works, what happens when somebody gets addicted, the difference between addiction and physical dependence, and then how to use a medication to help treat that so that person can have a chance of maintaining their sobriety.
Thank you, Catherine. My last question is really for Jan and Julie, but really just your own thoughts. And we're talking a lot about collaboration, but What do you see as a value for interagency kind of collaboration, and how might that work?
Thanks, Marian. Julie, do you wish to go, or I can?
You went off mute first, so I think you're on.
Okay. All right. Well, I think there are an enormous opportunity for collaboration, as everyone on the panel was describing, at whatever level it's happening. I mean, the importance of not recreating resources that already exist, and ensuring that we're all sharing existing resources, or however people are able to, pull them together in a repository. But I also just think in, work groups, that term can be overused. You think, oh gosh, is it really helpful? Will it really make a difference? But I think there are really great opportunities through cross collaboration, through work groups, when it's really focused on what the exact charge is. So there's a recent example with the Behavioral Health Coordinating Council, and it's to exactly do what people have mentioned here, thinking about ways to help ensure the greater collaboration between physical health and behavioral health, and what that looks like, and whatever that particular topic is. So I think that's an opportunity to break down those silos and barriers, and to ensure that there's collaboration that's really focused, and with an outcome of hopefully improving the health of Americans in all capacities across the United States. And so I think that opportunity for collaboration that's really focused and time specific still has great utility.
Thanks, Jan. Julie, last word?
Yeah, well, we've definitely spoke with a lot of different agencies across the federal government, including Department of Defense. They definitely want to start working with academic detailing and try to get that incorporated into their programs. CDC, and they've been doing some academic detailing, and we have talked with them multiple times. Indian Health Service, Public Health Service. So a lot of the different agencies have talked with us. And we are definitely ready to help folks if they want to roll things out. Our materials are always shareable to anyone, and people pilfer off of them all the time, and we welcome that. And so that is definitely something that happens. And I agree. The thing with our modality, it's very simple, but it takes dedicated time. And that's the thing that people really have a barrier to when they're first looking at, you mean I'm going to get a pharmacist or some other highly paid professional who is just going to go out and talk with people. Can't I have my clinical pharmacy specialist who's seeing patients also go talk to that provider on their, free time or extra time that they're not seeing patients, or my nurse practitioner, or whoever, my pain specialist, who can do that? And what we found is people really need dedicated time to do this job, or it's not going to get done. It's going to get piled under everything else, and they're not going to get the work done that they need to get done. When people have dedicated time, they have dedicated resources, they know what they're doing, they know what their expectations are, everything's clear, who they're going to see, what they're going to see them about, what outcomes they're trying to look for, and how often, we can go through into how many times they need to see them to really make a change, all of those things. If they're able to do that, it works. If they're able to just scrap whoever they can, it's not as effective.
Excellent. All right. Well, I want to thank all the panelists for a very good discussion. And we also thank you for all that you're doing with provider education. So we're going to take a short break. We ask that everyone return. We'll say 2:43, and we will be back, and the next panel will begin. Thank you. All right. For this session, we'll aim to build on the discussions we've had throughout the past 2 days, and consider how FDA and other stakeholders can most effectively improve opioid prescriber education to better address the evolving opioid and substance use crisis. Our panelists for this discussion are Travis Reeder, Associate Research Professor at the Johns Hopkins University Berman Institute of Bioethics, Graham McMahon, President and CEO of the Accreditation Council for Continuing Medical Education, Lisa Robin, Chief Advocacy Officer at the Federation of State Medical Boards, Marie-Michelle Lachey, Director of Clinical Education at the American Academy of Physician Associates, Alistair Martin, Assistant Professor at Harvard Medical School and National Organizing Director of Get Wavered, Also, Alistair is currently a White House Fellow and in the Office of the Vice President, but I am one to emphasize that he is not here today in that capacity, and he is not speaking on behalf of the administration. And finally, we have Sean Mackey, Chief of the Division of Stanford Pain Medicine. And now, much like the panelists before, we will ask each of our panelists to give a opening remarks. I'm going to turn to Travis to start us off.
All right, thank you for that. Really grateful to be here. Thank you for the invitation. So what I'm going to do is I'm going to spend my 5 minutes or so talking about reframing opioid prescribing goals. So you can go ahead and move to the next slide. So I'm largely giving a sort of summary view of a lot of the work that I've done, a lot of the teaching that I do in various CME courses. Obviously in 5 minutes, it's going to be pretty intense. Happy to talk about any of this at more length during the rest of it. And I have no relevant financial disclosures to make. Next slide. So here's the reframing that I want to make. When I first started getting into this conversation now 5, 6, 7 years ago, there was a lot of talk about we need to prescribe fewer opioids. And as a matter of fact, one of the first workshops that I got invited to speak at was for a surgery center. And the title of the workshop was Towards Opioid-Free Surgery. And when I was invited to give the talk, I wrote back to the organizers and said, I'm happy to come speak to your surgeons, but is it fair game to ask whether the title of this talk is a good one or not, or the title of this workshop? Because I think opioid-free surgery is a terrible ideal. And if that sounds surprising, it shouldn't, because opioid-free surgery out of context doesn't apply to any patient. So it's a very strange goal to have opioid-free anything as your primary goal if opioids are in fact important parts of healthcare for particular patients. So what I began to do in the following years was to try to make a turn from fewer opioids or opioid-free arthroplasty or opioid-free clinics or emergency departments. And then of course there was the backlash to that. And so there are various advocacy organizations saying we need more access to opioids, and well, more opioids is just as bad a goal as fewer. And so ethicist, right? So hammer, nail. I said, well, let's talk about responsible opioid prescribing. Next slide, please. So this is a very quick summary of the sort of view that I have begun to articulate over several years now. It's included in a lot of my CME courses. And what I want to do is break down the idea of responsible prescribing into 3 component parts. The main lesson of that is already on the screen, but I'm going to go through each one in just a little bit of detail. But the main lesson is just that we often focus on appropriate initiation. So the question, if we're asking, should we prescribe opioids, then we're thinking about like, should we in fact write the prescription in this instance? The only relevant question being asked is about initiation of opioids for pain care. And so a big part of the lesson that I want to make is that responsible prescribing goes much further than appropriate initiation. It asks, should we prescribe opioids, and if so, when? But then also, how should we manage them over any term, any length of time? And then how do we appropriately discontinue opioids? So focusing first on initiation. Next slide, please. One of the things I think is really important is to highlight how difficult even this first part of the conversation is. And so a lot of data has come out in the years that I've been working on this. We had very little data about what sorts of opioid needs patients of different kinds had. For gallbladder surgery, do you need any opioids? If so, how many pills? But even on this very specific case where we can generate a lot of evidence about what's responsible based on people's needs, there is a weighing of benefits and risks. And the reason I put this scale up here is to help us realize and to help us think through that if one of these is in the conversation as a sort of backdrop, then we have a really difficult time of doing a transparent, rigorous balancing. And so one of the concerns that I have is that in an era of a drug overdose crisis in North America, we talk so much about the risks of opioid exposure that we aren't very good at actually weighing out these scales, because every intervention, every clinical opportunity that risks of opioid exposure is weighing very heavily. And And it takes a lot of conversation about benefits before they even really register. So we've weighted the scale in some ways. I think that's problematic, just as problematic as if the benefits were overly weighted, which in the last 30 years, we've had an era of that as well. And then this justice circle over here on the right is to point out that it's not just about balancing risks and benefits, it's about doing it in a way that's fair and just, which is also really hard because clinicians are humans and humans have biases. So we've also generated a lot of data in the last 10 to 20 years about the racial biases that clinicians carry around with them and how this leads to more aggressive prescribing and taking pain complaints more seriously for white patients compared to patients of color, but also to male patients compared to female patients. So not only is weighing benefits and risks of opioids difficult by itself, it's very difficult to do in the context of just routine human biases. And so we have to do not causing harm, providing benefit. So here you hear the medical ethicist in the background, right? Beneficence, non-maleficence. We have to do it in a just way as well. Next slide, please. Okay, so that's a lightning look at how you think about it, how to think about appropriate initiation. But there's the second component, which is, okay, supposing that opioids are reasonable and responsible for some cases, which I believe that they are, what does it mean to manage responsibly prescribed opioids? Next slide, please. And I think the most important lesson here is that we had a sort of prescribe and forget mentality for a long time. And so the way that I tend to think about it is, for much of my life, going to the physician, if there was opioid conversation to be had, they were treated relevantly like antibiotics. You didn't need a lot of specialty training. They aren't that complicated a drug. You write your name on a prescription pad. If you're the clinician, you hand it over, the patient goes home, and that's all that's necessary. What I'm arguing for is that real management requires regular checking in, perhaps behavioral health assessments, especially over longer prescriptions, screening for signs of misuse and developing use disorder, but also just for routine physical dependence, which we know happens, and checking for understanding. So there's a big educational component where we really think about prescribing opioids as having a genuine informed consent component. Next slide, please. But even if you've prescribed opioids appropriately, initiated them, that is, and you're managing them appropriately, there is this requirement for discontinuation appropriately. So last slide, please. A lot of my work has centered around tapering. I can discuss that more if there's any interest, but this picture here is of David Sherlink, who's a physician who has used some of my work and a lot of his teaching. So now I shamelessly steal his line when he teaches his residents and fellows and med students. He says, don't fly a plane if you don't know how to land, which is to say responsible prescribing requires knowledge and ability and willingness to deprescribe. So I'm not going to teach you how to taper opioids here, but this is just on the screen to show you there are lots of resources for learning how to taper opioids. And I think it is a requirement for responsible prescribing. And that is the end of my time. So thanks very much for your attention.
Thank you very much, Travis. Next, we'll turn to Graham.
Thanks, Marian, and hi, everybody. Very nice to be able to have a conversation about something that's near and dear to my heart as a prescriber, as a physician, and someone who cares for patients in chronic pain, but also as an educator. I've been an educator for many years, but now oversee the continuing education infrastructure that we have for physicians and collaborate to a great extent with our colleagues who are accreditors for a variety of other professions, including nursing and pharmacy. I don't have any financial disclosures either, like Travis. Next slide. I think Travis really illuminated some of the key problems that we have as a system. We have a lot of strengths in our system, but we also have some key problems in this particular area. And just so it's clear, some of the strengths that we have in our system is we have a diverse and highly capable community of continuing education providers across the professions that are distributed and nested in communities of all sorts all across the country. And they've demonstrated remarkable capacity to drive the power of education to make behavioral change. And that's a community we can leverage, engage with, and support to do the work that we're describing here to make a difference in quality prescribing. But in order to elevate that community and help them do their work, we have to create the structural foundation on which they can be successful. And that's our job as the community on this line, is with the FDA, with other regulators, be responsible in how we create the infrastructure to allow high quality education and behavioral change to occur in those communities. We have several key problems that I think I'd like to illuminate. The first Travis already built on, which is this acknowledged issue that prescriber confidence is not aligned in many cases with their competence. Many prescribers continue to prescribe and forget, as Travis so eloquently described, and do not follow up on pain management with their patients. They may use opioids inappropriately, either under or overuse, and they may not follow up and recognize opiate overuse disorder or opiate use disorder and be able to manage patients who show signs of that disorder. The challenge for us as educators is that if clinicians, if prescribers don't recognize that they have an information gap or a skill gap, they're very less likely to engage in productive education that's going to drive their individual competency. That is also based on the fact that you're most likely to be successful as an educator if you can identify an individual's gap, communicate it to them, and use their motivation for mastery to engage in positive behavioral change and support them in that journey. We don't have consistent or even ready feedback to individual prescribers as to identifying their opiate use in their practice in a reliable and consistent way. And we don't have a way of sharing that information with educators so that they can target education at appropriate groups. I suppose from a structural perspective, one of the things that worries me to a great extent is that we already, the FDA requires the REMS program companies, these 67 or so opioid manufacturers in the United States, to contribute millions of dollars to a central fund that's managed by the REMS program companies. But that money, in our view, in my view, is not well managed. There is a grant application process, but it has not embraced a diverse group of educational providers to meet the needs of the extremely diverse needs of our communities. And we have the same consistent group of organizations delivering on that grant application, admittedly with high quality accredited education, and they are doing great work, but it could be much better. One of the challenges is that we have a tendency to reward and encourage checkbox completions that create an appearance of educational efficacy without the kinds of robust educational outcomes that the National Academy of Medicine in their more recent report that we contributed to with our colleagues in nursing and pharmacy and others. But that's not what the community needs. We do not need information transfer, which is the lowest level of educational efficacy. Rather, we need competency development, not just identifying which competencies should be created for individuals, but also driving education to demonstrate the achievement of those competencies so that we can create safe and effective prescribing. And as we've talked about over the last 2 days, the FDA blueprint is unnecessarily restrictive in not allowing customization to an individual learner or group, the educational expectations. So structurally, we've facilitated a grant process and the expenditure of millions of dollars in ways that are not in the best interest of the community, that we already know about and are easy things to fix. Next slide. The next 2 slides are from the work that we've done with the National Academy of Medicine, and they may be familiar to those of you who've looked at those reports. But we really need to think about educational efficacy in terms of the standard learning cycle, create the type of reflection or self-insight that will drive educational engagement, that will then create the learning outcomes that create the behavioral change that drive population change. But in order to do that, you've got to create a robust and high quality learning environment where people feel safe and supported, where the education meets their practice-based needs, where they feel like they're doing right by their patients in managing their pain effectively and comprehensively, and where they're working with their team members across the professions to improve their performance together based on data that we can all agree is meritorious. Next slide. From an observation of the necessity of that learning cycle come a couple of pretty pragmatic recommendations, both from the National Academy of Medicine and from me as an individual clinician and prescriber, that we need and can do if we work together to create the collaborations that work. Too often, I think those of us who care about this talk to each other all the time about the importance and need for change, but ultimately not much changes. So I've tried to be very specific and pragmatic, as has the National Academy of Medicine, in what they're able to do. So to clarify those elements, next slide, I've kind of crystallized them into this last slide, which is really the recommended solutions that we have put in place. Educators have clearly demonstrated their ability to meet educational expectations very well. Accredited education and accreditation manage that for you. But we would really like to see the FDA require the REMS program companies to respect the determinations of this volunteer and for free independent grant review committees that the joint accreditors have put together with our colleagues in nursing and pharmacy, make those funding amounts and decisions transparent so there isn't an appearance of impropriety in some way, that we eliminate the requirement to fulfill the entire blueprint to give organizations educational flexibility, and allow test outs and expect competency specific outcomes. We also have a centralized data system that we're happy to leverage and use for this purpose. And we're, as accreditors, happy to audit the systems to ensure compliance and that the regulators are happy. We would love to see, and my colleague, Lisa Robin, will follow me, talk about the value for collaboration around PDMPs, but also about recognizing nationally appropriate accredited educational activities as meeting state requirements, and then ultimately create the collaborative research efforts that will identify these practice gaps, harmonize data, and produce an annual report that will help us stay on track as a community. Thanks for your time.
Thanks, Graham. And with that, we'll turn to Lisa.
I really appreciate the opportunity to be here today. And I too have no commercial interest or financial relationships to disclose. So the FSMB has had a long history of supporting states as they try to develop and implement strategies to address the inappropriate prescribing of opioids. This continues to be a priority for our boards. As every year, we just completed a survey of all our boards, came out as the top problem area for boards. And so the Federation tries to provide some guidance in these areas as far as policies, as well as trying to provide educational resources or point them in the right direction. FSMB also participates on the National Academy of Medicine's Action Collaborative on countering the U.S. opioid epidemic, as well as the Action Collaborative on physician wellness and resilience. We also had a representative that participated in the education and training work group. Next slide, please. As a resource, we do have a web page dedicated for resources for state boards that has all of the state policies. I think it can be quite a challenge for physicians and other health professionals trying to navigate the various rules and requirements, not only as far as prescribing goes, but also dosing limits and other legislation that has been enacted that designed to address the opioid epidemic, and some have been all well-meaning, but some maybe have been somewhat ineffective. What you see now are only 11 states don't have mandated education around opioid prescribing. The majority of those would not necessarily recognize the REMS education for meeting their requirements. And so it can be extremely challenging and burdensome for physicians to have to keep up with those various requirements with the Interstate Medical Licensure Compact that now has about 37 jurisdictions as members. Physicians are practicing in multiple states, and this, I believe, is going to put additional pressure on to try to ease some of that burden and somehow harmonize our CE requirements. Next slide, please. But today, I really wanted to spend some time talking about a new collaborative, and this really builds upon the work of the NAM collaborative. And for the first time, it's a collaboration of the organization representing licensing boards that license over 5 million healthcare professionals. That would be the American Association of Dental Boards, the Federation of State Medical Boards, the National Association of Boards of Pharmacy, and the National Council of State Boards of Nursing. This was launched last fall, and their goals really are to share resources and strategies to try to reduce opioid substance use disorder among the public and healthcare professionals, because as I said, is one of our priorities is certainly looking at the wellness of our healthcare workforce. To seek better alignment of state policy guidance across the health regulatory boards, partner and support initiative of other healthcare organizations, such as including the National Academy of Medicine's Action Collaboratives. We have developed a dedicated website that will have resources and will also continue to grow. Next slide, please. The ORC held their first Invitational Summit in March of this year in Washington, D.C., and it was attended by about 75 representatives from the 4 organizations, and we had a very distinguished panel of speakers, as you can see, and we addressed 3 major topics. Education was one of the top topics, and really also led to breakout sessions where the attendees could really talk about specific strategies and a direction that perhaps this collaborative may move toward in the future. We also discussed risk reduction and accountability, as well as new trends in treatment. In addition to the organizations represented, we did have representatives from SAMHSA, from the DEA, CDC, and FDA, and appreciated their support. Next slide, please. So we did have some opportunities that came out of this summit to really a commitment and a sense of urgency about improving harmonization of policy and CE requirements, addressing stigma, looking to increase access to care and for medication-assisted treatment. And this collaborative will continue to identify focus areas and commit to action on behalf of these opportunities. The next step, we will have a commentary published as a result of the summit, and a call to action will be stated in that article. There will continue quarterly meetings, and also the organizations will be participating with the FSMB as our new board chair has identified this as an area for policy revision for FSMB to look at our policies around prescribing as well as treatment, to bring those current, and also then to use those as a means to begin this harmonization. And really they are intended to be interprofessional of use to all of the professions that are involved in the whole patient care team. Next slide. And thank you for the time today. Look forward to the questions.
Thank you, Lisa. All right, next we'll hear from Marie Michelle.
Good afternoon, everyone. It's been a long 2 days and it's been very informative. And it's going to be interesting to see that a lot of my remarks are going to be very similar to what's been said by many of our previous presenters. So I work with the American Academy of Physician Assistants. I have no disclosure other than I am an employee of AAPA. Oh, and I just made a big boo-boo because we are now the American Academy of Physician Associates. So we represent a profession of more than 150,000 PAs across the United States, the 50 states, the territories, DC, and the uniformed services. And PAs are authorized to prescribe in the states that they are licensed to practice. I'm going to briefly address how AAPA covers what I see are the three educational domains that are fundamental to the opioid crisis. First off, we have to address pain and its management. We need to address substance use disorder and therefore safe opioid use. And of course, the public health issue that relates to the opioid crisis, which is that we need to have a better understanding of SUD as well as how we manage and treat patients with SUD. And then how we actively engaging PAs in the management of patients. Because as clinicians, PAs are specifically attuned to treat patients with any type of, or not even treat, but even address if they cannot treat patients with SUD, because they are being seen in all of the medical specialties that PAs are practicing in. Some of the things that AAPA has done is that we've mobilized PAs to improve patient outcome. And one of those is we've developed toolkits that are that have been identified because of what AAPA has seen as being national health priorities. One of them is a substance use disorder toolkit, which we basically have put educational material, resources, patient screening tools, resources, and referrals for PAs that are involved in the care of patients. The other thing that that I want to say is that when we look at pain management, we have to look at, we need to identify the gaps of what is being offered and what has been offered, and how has these been offered. So for example, in 2010, AAPA Clinical and Scientific Council wrote an article in JAPA, which is the journal for PAs, which they, the article was opioid use and chronic non-cancer pain. And in that article, PAs could earn credit after doing a post-test. But the article highlighted some of the same issues that we're seeing today, 12 years later. Opioid therapy, when appropriately provided, is useful for short-term pain control, and that there's weak evidence for long-term use. That the best outcome that is found in our patient population is if we have a multidisciplinary approach to the management of chronic pain. That we need to have clear, consistent documentation. That we need to really engage patient and use the patient-provider agreement, and even sometimes the patient-caregiver provider agreement. That we need to be cautious when we are using polypharmacy, because we want to make sure that there are no other combination products that could be a problem. And of course, we need to educate patients in their role on how to help with not have issues with diversion. That same year in 2010, AAPA began a long-term partnership with the Core REMS Collaborative, which is one of the, or right now not, but has been one of the RPC-funded educational initiative. And it was a 9-member professional organization led, where we were able to provide CE to, on an interprofessional level, to our constituents, so PAs, NPs, physicians, family physicians, DOs, physician in palliative care. And those programs were aligned with the FDA's mission and the blueprint. We indirectly are still, AAPA is still providing the RPC funded activity through one of our partner organizations, where we have been able to host a current activity that addresses pediatric pain. We introduced a performance improvement initiative many years ago in a large healthcare system, which was of course multidisciplinary and interprofessional, where we wanted the prescribers to be able to reach level 5 and hopefully level 6 of the more level of outcomes performance measures. The second point that I want to touch in is the substance use disorder. So we need to have a robust educational program that, while addressing safe opioid prescribing, We also need to address substance use disorder. They cannot be siloed. It's the same issue that we need to address in tandem. And that has to be included in future healthcare provider education, not just the prescribers. And PAs, as we all know, are involved in the management of patients with SUDs. They are able to prescribe buprenorphine for patients who are indeed in need of MAT therapy. We've collaborated with ASAM and AANP to provide the buprenorphine waiver training to practicing PAs, and PAs continue to use that course even though the hour requirement is no longer needed. The 24-hour requirement for PAs is no longer required. The other thing also, and Catherine made allusion to that, the Physician Assistant Education Association has introduced the buprenorphine waiver training in the 282 PA training courses. So again, starting early during the training of PAs to get the conversation going. More current, in 2019, AAPA did a practice survey where we asked our PAs whether or not they held a buprenorphine waiver. And we wanted to address what were the barriers that they face in obtaining a waiver, and more broadly, what level of competencies they had as it related to diagnosis, treating, and managing patients with SUDs. And one of the barriers that they address is that those that did not seek a waiver, and it was because they lacked the confidence in their ability to manage appropriately patients with OUDs. And it speaks to the gap that we have with the desired skill and ability of patients, so current versus desired skill in their ability to practice. And then the other gap that was widely mentioned at over 60% was a lack of training. The previous panel, there was a question that was raised about how do we integrate patient in this discussion. In 2016, AAPA hosted a movie that's called The Hungry Heart, and it addresses Suboxone therapy in a pediatric practice in Vermont. And we provided the movie, and after the movie, we had a facilitated discussion with an addiction specialist and 2 adolescents in the community that PAs could actively ask questions on, what were they thinking? What was going on? How were they able to navigate the therapeutic options that they were being offered, and the other psychosocial issues that were of concerns to the patients during their therapy and their ongoing therapy to manage their substance use. The PA Foundation is also actively engaged in educating our PAs. One of the tools that we're using right now, that the foundation is using, addresses stigma. I'm almost done, thank you. And the stigma was not just the patient, but also providers, and the stigma that the providers, that the patient have to face when they're treating patients with opioid use disorder. And the last comment that I want to make is the issue with the licensing boards, where, again, there is not consistency among the licensing board for PAs. 43 of them require that PAs have CME in opioid prescribing or pain management, but even within the different states, these are very different. So I'm going to stop right there, and then there are other issues that I can raise during the panel discussion.
Excellent. Thank you so much. All right, next we'll turn to Alistair.
Hi, y'all. Thank you so much for inviting me, and thank you to the team at Duke for setting this up. I know how hard it can be to make sure that these all go off without a hitch. I have no conflicts of interest to disclose, but I do have an FYI to share. I'm reporting live to you here from the White House, where I work in the West Wing Office of Public Engagement and also for the Vice President of the United States. But I'm here in my personal capacity, so everything I say cannot be attributed to the administration. These are my views, my experiences, my stories. Speaking of stories, I want to tell you a couple of stories. I don't have any slides, I don't have prepared remarks, but I want to try and share a couple of the impactful stories that motivated me to get involved in this work, and the stories of how my initial motivation needed to be deployed in a way that was tactical and strategic to help my hospital. Now hospitals across the country get their providers waivered and get EDs prescribing buprenorphine, which is what we need. My story starts one night. I was an intern in emergency medicine back at my home institution in Boston. And it was maybe 2 or 3 o'clock in the morning on a Friday night. And I had this young lady in our waiting room who came in with her suitcase in the waiting room. For the ED docs that are on, you guys recognize this as positive Samsonite sign. And positive Samsonite sign is never a good sign. That means the person is intending to stay for a while. And so I bring the woman back and I get her story. And she tells me, Doc, look, I'm a mom of 2. I have been struggling with opioid addiction for the last 5 months. She had fallen down the stairs at her son's daycare and had broken her left ankle and had a tremendous ORIF surgery, an opioid reduction internal fixation surgery, and was put on opioid pain medications and was discharged. And over the last couple of weeks before seeing me, she realized that there was something wrong. Every time she lapsed and didn't take the medication, she felt off. She felt abnormal. She felt like she needed it. She ended up using pills that were left over in kitchen cabinets and cupboards of her family's home. That persisted for a couple of weeks, and then eventually she ended up finding a dealer in the hometown that she grew up. And she started buying pills immediately. That night, though, she realized that there was something wrong and she was absolutely going to get over this. And so she sent a stern message to her dealer, said, look, I'm done. I don't need this anymore. I didn't sign up for this life. Lose my number. I'm going to get help. And the dealer said, absolutely, no problem. And she actually showed me the text message. She said, no problem. Good luck. About an hour and a half later, she heard a knock at her door. She went downstairs and it was her dealer. And the dealer said to her, look, I know you're getting better and you're going to, but recovery is hard. Why don't you take a couple of pills for the road? She took the pills, and her husband saw this, intervened, and brought her to me in the ER at 2 a.m. on a Friday night. I'm an intern. I've been a doctor for all of 1 month. And what do I tell this woman? I say, of course, we're going to help you. That's why I got into this. It's what this hospital is made for. Of course, I'm going to help. I went to my attending physician. For those of you who don't know what that is, these are the folks who sort of run the show in the department. You got to run the plans by them. And I said, look, we got this woman who needs help. We've got to get her the treatment she needs, and I want to admit her. And the attending physician said, I'm sorry, that's just not what we do here. Discharge her. That was about 7.5 years ago, 8 years ago, guys. And I have to tell you, I have no idea what happened to her. I think about her a lot, and I hope she got better. But what I'm sad to say is that she was just one of dozens. Fit the same mold. And for those of you listening who are on the front lines, who are practicing, you have dozens of your own stories. And so the story I want to tell you today is about how someone who has no specialized training in this, I do not have any specialized addiction fellowship training. I did not take time out to get a PhD in addiction science. I don't purport to be an expert on this, but I care. And I think that's the person that we need to build systems for and motivate action for. And so what I did with that triggering event for me was I started thinking about how do we begin to address this problem in my ED? And the first thing I noticed was the idea that out of the 52 emergency physicians that we have in our department, only one of them had their waiver. And so we started a program called Get Waivered at our hospital, where we identified 2 important concepts that I think are going to be the lessons that I want to share with you today. And I'm very excited to get to the panel where we'll talk a little bit more about this. But the 2 important lessons for getting folks in our department waivered were, number one, the importance of segmentation. So I come from the world of politics here. Political segmentation happens all the time. And segmenting the groups that you're working with to understand how to best approach them, I think is something we could learn a lot about if you were thinking about campaign execution and campaign management in the hospital. That's the first lesson I'll tell you a little bit more about. And the second was to be clear about what the specific barriers are for each segment of the universe of people you're trying to motivate action out of. And so with our department, we identified there are 3 different segments. There were people who were already on our side. They totally agreed with the idea of treating patients with medication. They were ready to go. They just needed to be activated. Then there were folks who were totally against us, absolutely not on board. We're not interested. This is the dumbest idea. Why do we have to go above and beyond for folks that won't do it themselves? That's sort of what they said to us. And then there was everyone else, people in the middle. And I'd say that roughly we had maybe 10 to 15 in the 4, about the same in the against, and then the remainder about 20 or so in the middle column. And so our approach was motivate action and activate the base of people that are interested in doing this first, get them excited, get them engaged, and have them talk to the people who are on the sidelines, that middle group, and get folks to make the decision to get waived. The last group, you might be thinking, well, what do you do with the folks who are against you? The way that we approached it was similar to how we approach these things in political campaigns, and that is you ignore them. The more that you activate, provoke, and set up a reaction, the more that you spend time fighting that battle. And the secret is, if you can activate the base, if you can mobilize the middle, at some point it just becomes shameful, right, to be in that last group when 70% of the department is already on board and you're not. It's hard to explain. So that's the first lesson I want to transmit in terms of political segmentation. The second is around barriers. And this idea of being clear about which barriers are pertinent and germane to which group. And so with the folks who were for us, they had a different set of barriers we had to be tactical and address than the folks who were on the fence. But I'll tell you one thing, and I would love to get into this when we get into the panel, but the one unifying theme that worked across all the groups was the concept of salience, what behavioral economics describes as salience. When you tell captivating stories or engaging narratives, when you anchor the lessons, the narrative, and you bring real people, the message sticks. And I'll give you an example. At every one of our waiver training sessions, we always made sure to be diligent about not just training providers to give them the information they needed to tactically do this work and apply their new waivers, but we also brought patients who were in recovery. And I want to tell you one of those stories. We had one of our patients who was a frequent flyer, who we brought to one of our waiver training sessions, about 20 ER physicians in a room. And this patient was well known to the department. And most of the ER physicians, when this patient walked in a suit and tie, nearly fell off their seats because we had assumed this person was dead, had overdosed, or had succumbed to some illness, sequelae of opioid use disorder. And here he was, suit and tie, and beaming and smiling. And he told us his story. And the first thing that he said to us was, y'all, I'm a little nervous to be addressing you today. But the reason why is because actually this is the second most exciting speech that I'm giving this week. The first was proposing to my fiance, which I did yesterday. And she said yes. And so he then proceeded to tell us the story of how he got his life back together using medication for addiction treatment. And these are the stories that motivate action among healthcare providers. When you make clear what's on the line and how these solutions work for people, they tell new stories to themselves about why this is important. And until we start working on how do you change hearts, you can't really expect to get far with changing minds. The last thing that I want to share with you is it's not just about getting a waiver. As you all know, there's this concept of the ghost waiver, which some studies demonstrate that over 60% of people who have their waivers never even use them. And so our department was diligent about leveraging behavioral economics to actually get people to use their waivers. And there's a number of things I could share with you on that, but the two important little tidbits I want to share today with you are, one, you have to make it easy. And the way we did that was everyone got what we call a badge backer. And on the back of your badge, the whole entire protocol was right there in one sort of visual snapshot. So you didn't have to think about it. You didn't have to scurry through your email. It was right there on you. The next thing was the importance of making doing the right thing observable. I'll repeat it, doing the right thing observable. So we started a campaign where we shouted out healthcare providers who were getting people onto medication for addiction treatment. And we would send out an email to all 250 staff members of the department that says, Dr. Robin, excellent work last week. Because of her work, she helped a young pregnant patient get started on medication for addiction treatment, and she made her follow-up appointment. And we keep that going today. These are the kinds of things that I think ultimately will move the needle. I'm going to close with one more story, and that is, remember how I told you when you're politically segmenting groups, thinking about sort of the group in the middle, and the group that's anti or against. And I told you, it's often best to conserve energy and kind of ignore that last group, the anti-group. Well, I broke my own rule once, I spent some time interviewing one of the providers who was in the anti-group. And she was desperately anti, absolutely not involved, not interested, not engaged, didn't want to do it, was not interested in providing buprenorphine. And I said, help me understand, why, what's behind it? And she said, well, I have to tell you, Alistair, it's complicated for me, but I can't help but think back to when I was a resident about 20 years ago. I had an old attending male attending, who was anti giving medication for abortion. So if patients needed to have a medical abortion for whatever reason, this attending would tell his residents, absolutely not in my ER. And she recounted how she felt as a resident, where she knew that the right thing for the patient was to prescribe this medication. But the attending and their own personal philosophy was sort of inhibiting that or getting in the way. And she felt like she was potentially doing the same thing. And so I tell you that story because often with the folks that are not interested, that are not engaged, that don't want to be part of the solution when it comes to medication for addiction treatment, they often have extremely complex reasons. And I think the lesson that I learned was listening, because once she felt heard, she was on board, and we got her to get her buprenorphine waiver, her X waiver. So with that, thank you very much for having me, and I'm excited to engage in the rest of the panel.
All right, thank you so much. And finally, we're going to turn to Sean.
Thank you very much. And I'm honored to be here with you all today. I've listened to most of the sessions, and I've been incredibly impressed with the depth and the breadth of the knowledge and expertise of the speakers and the panelists. Indeed, I've had to rewrite my comments 3 times to avoid overlapping with all the other speakers. It's not easy being the last speaker of the last session and asked to come up with something that hasn't already been said. By way of introduction, I'm a professor and chief of the Stanford University Division of Pain Medicine. I'm an NIH and FDA funded physician scientist, educator, and I care for people living with pain. I served, relevant to this workshop, I served on the National Academy of Medicine committee that developed the Relieving Pain in America report. And I also co-led the development of the HHS-sponsored National Pain Strategy, which, by the way, I'd love to see fully implemented by the federal government. I'm going to be drawing upon those reports and activities and my own experiences in my comments and recommendations today, and I have no financial conflicts of interest. I was asked to give specific tactical policy recommendations that the FDA and other stakeholder organizations can take to improve prescriber education and to avoid high-level gaps and recommendations put forward by others. I will therefore put forward 4 recommendations that either haven't been addressed or that I wish to emphasize that I think will have an impact. Recommendation number 1, promote, brand, and market the programs and materials developed. Now, I've witnessed a recurring problem with programmatic efforts to improve pain across the federal government, the National Academy of Medicine, and other groups. And that problem is that when the effort is completed, the effort and group is sunsetted and it's left to the members of the committee to ultimately promote. There's frequently no budget for subsequent media promotion or development of advertising materials. And by way of example, the NIH over the last several years has supported the development of over 50 interactive case-based video materials on pain and substance use disorders through a program called the Centers of Pain Excellence, or COPES. And the problem is hardly anybody knows they exist outside of the sites that created them. And there are many, many other examples. I was co-leading a National Academy of Medicine report on temporomandibular disorders. And when we were done, we were thanked and we were told there's basically no money left to advertise the effort. We need to ensure that future budgets for these efforts include appropriate promotion, branding, and marketing, particularly through social media sources, to improve engagement so that that knowledge gets in the hands of all the relevant stakeholders and users. Recommendation number 2. We need to better coordinate efforts with other federal agencies and stakeholders to reduce overlap and optimize impact. Now, this one was mentioned in the last session, but I kept it in and decided not to rewrite it. Let me build on it. In the National Academy of Medicine Relieving Pain in America report, we recognized that there was no federal coordination of pain research amongst the NIH institutes and other federal agencies. There was duplication of effort, there was inefficient silos that had been developed. We called for the implementation of the Interagency Pain Research Coordinating Committee, or IPRCC, to bring together and coordinate these various governmental efforts to advance pain research, and that's worked out really well. This effort, led by Linda Porter at NINDS, has helped bring together the relevant stakeholders to coordinate pain research across institutes and across other federal groups, and we need to have a similar coordinating effort around this topic. Recommendation number 3, we need to train the trainers. This one was also touched upon during the last session, but I'll build on it. Since post-licensure clinicians are not going to benefit from pre-licensure education, we need to retrain our current frontline clinical workforce in both pain and then also in substance use disorder management skills. In other words, we need to develop more of the train the trainer models. There are excellent models that were discussed in the last session, like what Joanna Katzman mentioned in Project ECHO. I want to mention a recent one also that was developed by Dr. Scott Fishman at UC Davis called the T3 Fellowship. There, they take primary care clinicians, they train them in basic concepts in pain and SUDs using an interactive distance-based learning with direct one-to-one faculty mentoring. Now, while I'd love to see an increase in the funding for training of additional pain medicine fellows and addiction fellows, I have to recognize that primary care clinicians are ultimately on the front line in pain and SUDs, and we need to further expand and support these efforts to get them trained at the post-licensure level. Finally, recommendation number 4. We need to invest in IT tools that are going to support clinicians in prescribing and also to support educating our trainees in how to do evidence-based pain care. Now, in the National Academy Guidelines and the National Pain Strategy and other reports, we've called for the development of learning healthcare systems. These are IT platforms that bring together clinicians, scientists, patients, and administrators in an informatics platform that collects high-quality data to improve the care of people with pain and other medical conditions. What is clear is that our reliance, our hope that the electronic health record system would save us has been an unmitigated failure. They were never designed for that purpose. So starting about 10 years ago, I started on a journey back then to create an open source, in other words, free learning healthcare system that we called Quire, which we use to collect patient and clinician reported data and to use that to optimize the assessment and care of the treatment of the persons in pain. We've done this for hundreds of thousands of patients. We've given the system away to multiple academic institutions in the US, Canada, and Israel. We've integrated targeted digital therapies based on patient characteristics, and we've embedded these systems into EHRs using contemporary FHIR technologies. Now, patient-reported outcomes, or PROs, were touched upon several times during this workshop, and it's an important topic. However, I submit that the challenge is not defining the specific PRO or screening tool. Rather, the challenge is to be able to embed these tools into platforms that integrate in with our clinical practice, that are better able to inform patient care and not just add additional burdens to our clinicians through the already clunky EHRs. Now, pivoting to the topic of this workshop, which is improving education, how does this all relate? Well, it relates because we need to better train our clinicians in how to better use such systems. As part of our fellowship training program at Stanford and in other systems, we teach our clinicians how to use high quality evidence and data to better assess and care for those in pain, both on and off opioids. We teach them how to use high quality patient-centered evidence to engage prescribers to support clinicians in prescribing and educate them in evidence-based pain care in a shared decision-making process. So in closing out, there's been a rich discussion yesterday and today covering ideas to improve prescriber education in pain and opioids. And I just wanted to build on this and offer 4 recommendations for consideration by the FDA and others. The first being promoting, branding, and marketing the materials that are developed. 2, better coordinating efforts within the federal agencies and the stakeholders to reduce overlap and optimize the impact. 3, to invest more in training the trainers. And 4, investing in IT tools to support clinicians in prescribing and in educating them in the basic principles of evidence-based pain care. With that, I appreciate the opportunity to be part of this terrific workshop, and I look forward to further discussions. Thank you.
Thank you, Sean. Sean, while I still have you on the screen here with me, and invite all the other panelists to join us so we can open up our discussion. But I'd love to dig a little deeper to your second recommendation, which it's really about how you were taking your example at NIH and finding a coordination that went into effect. What would be your steps for having something similar that was not just, perhaps one agency, but interagency, where, going from the comments from the last panel, we might not be just creating another workshop or work group for another work group's sake, but is there a way for us to have true interagency collaboration in a way that would improve provider education? And what might be the steps that we could take to make that happen?
Yeah. Well, I liked what the NIH did with bringing together the NIH institutes, the FDA, the CDC, ARC, SAMHSA, and putting them all in one room. They did a tag your it to one of the NIH directors. In this case, it started with Story Landis, and now it's Walter Koroshetz at NINDS. And they tasked a former program officer, Linda Porter, and made her director of pain policy. Now, at some level, they were taking on some of the education aspects too. There was a lot of discussion amongst them about different education efforts, focusing mostly on pain. But I really think this transcends what they're doing, because NIH is really focusing on research. So I thought their model worked really well, and I would encourage chatting with Linda about what her experiences were in creating the IPRCC efforts.
Excellent, thank you. Any other examples from our panelists on true interprofessional and intergovernmental collaborations that could move forward to put forth some of either the recommendations that Sean put forth or some that you have on your own? And just to state, Sean was absolutely right. We've put you all at the end of this session with the very kind of big task of saying, what do we do now? We've heard a lot about gaps. We've heard a lot about competencies, but is there a path forward, something that can be said for the various many stakeholders that we know are really committed to this issue that could help us move something forward? And so with that in mind and with that spirit behind it, I ask, again, are there some other interagencies that we could move away from the siloed approach that I've heard through many of your comments?
Well, I think the experience of the accreditors across the professions is probably salutary here, because it shows us that if you're willing to compromise some autonomy, you can create important collaboration that benefits everybody.
Mhm.
And that's true in the way in which we've approached our collaborative role to engage with the regulatory systems like the FDA. And I think there's value in that approach to respect the role of our colleagues and team members across the professions to create a better prescriber and pain management experience for patients in the communities. But it also requires organizations to actually do something. I mean, the accreditors have done a lot of things in this space to try and drive quality education and make impact, but we need some support from folks like the FDA to do the right thing and avoid us perpetuating this checkbox approach to education that is in nobody's interest.
Great point. Yes.
I just want to follow up on Dr. McMahon's point, and also give, I see Kate Wessel is on, Catherine Kate Wessel is on from the AAAP. Catherine will remember that at the beginning of the pandemic, the work that we were doing with Get Waivered was very local and on the ground, in-person events. And we'd gotten just under 1,000 folks waivered throughout the country vis-a-vis that program, sort of a road show of doing waiver training courses. But when the pandemic hit, we could not do in-person courses anymore. And so we approached AAAP and folks at SAMHSA with an idea, and that was to do these sort of mega Zoom sessions where we would just blow it up and see how many people we could fit into one Zoom room and get through a waiver training program. And I completely credit Jacqueline on this, because this had not been done before. We ran Facebook targeted ads and ran an Instagram influencer campaign with hashtags and tried to get the organizations to tweet out about this as well. We ended up getting about 1,200 people to join that initial waiver training program, waiver training session. And I think it's that kind of flexibility that we're going to need if we're going to really sort of move the needle. And AAAP and SAMHSA really stepped up in that way. And I know subsequent to that and in other ways, they've done really big Zoom sessions as well. But just want to give credit where it's due.
Great, thank you. And Lisa, going to your earlier comments about kind of the alignment and harmonization, you spoke a bit about, how that there's future opportunities, and you've already done so much work in the content of prescriber education initiatives. So where are our opportunities there, especially as telehealth expands providers' abilities, as the landscape continues to change and evolve? Where does harmonization fit? And kind of who's I like the tag you're it mentality that was able to be employed earlier, but how do we know who will be leading those initiatives?
Well, that's a great question and a very difficult one. So I think we have to
Lisa, I think we've lost you. Okay, we lost you for a second. Can you?
Oh, I'm sorry. Is it better? I've had a lot of trouble.
You're good now. Yeah.
Computer. Okay. So I think one thing with the medical boards, as they're very different, and it's a challenge to start working towards some sort of harmonization on that regulatory perspective for a couple of reasons. On the mandates on CE, it's oftentimes not driven by the medical boards or other health professional board, but it is a legislative piece of a legislator wanting to do something. And so then they put on these mandates on top of mandates for whatever the topic du jour is. And you'll see that around the country if you're looking at the specific requirements. But, we've had conversations with Graham and others, and I'm trying to bring something that from the ORC, from this being something that maybe they can drive their boards. It has to start with education with them to make them aware of the problem and look at maybe we have a solution. There are a few boards that, as I say, do recognize. There's a few boards that will recognize participation in continuing certification to meet CME requirements and those type of things. And with, the core competencies, as you find what really will transcend among the different specialties that we can, and then perhaps make that a part of everyone's continuing education and professional development. So I think we start with education. We have an annual meeting coming up, and Graham is going to be speaking, and we're going to start the conversation with the boards. And I think that, working with the agencies within the federal government coming together can really act as a stimulus and make things happen. So I don't think we can discount how important that would be. And I think, using the model that exists that Dr. Mackey talked about, I think that that's a great place to start. And so we'll see. It's a big job.
That it is. Thank you. Anything you'd like to add from that, Graham?
No, Lisa's exactly right. It's a difficult position because each board is independent and they're not regulated by FSMB. FSMB is just a collaboration of those boards. So they can't tell the boards what to do, and they make their own decisions. And often those decisions are not exactly in their hands. But there are things that we can do together to make sure we're all at least aware of the dilemma. And many physicians, of course, are multiply boarded, as well as multiple professions outside of the physicians are are licensed by multiple states. So it is a problem to solve. It's a bit of a gnarly one, but I'm sure we can work on progress towards a solution, which is why I think it's an important one for us to facilitate and be part of the conversation.
Excellent. Thank you. Marie-Michelle, I was wondering, kind of based on your comments at the end, I think it was the very last part was just talking about the kind of navigating between different kind of policies at state levels. And I'm wondering if you could speak more about kind of what those challenges are and what kind of policy changes you would love to see that would help kind of get over that as a hurdle for PAs.
Well, I think Lisa and Graham kind of articulate some of those issues in that even for the PA profession and among the various professions, the requirements are different from state to state. So there's an educational disparity that exists. And so it becomes very hard to have a harmonized outcome of what it is that the states want the clinicians to be able to attain. So for example, for PAs, a state could say that they need requirement in addiction. Another could be pain management. And they're mutually exclusive, if you know what I mean. And you have states where you have requirements that the education has to be given by a specific entity. And so, for example, a RPC-funded educational activity would not count for a safe opioid prescribing for that particular state requirement. So it's very convoluted. I think we need to really look at reducing the variation among state to state and harmonize what is required.
Excellent points. As we're talking about having concrete policy change, Travis, how do we keep the patient voice involved here, especially as we're talking about kind of changing the environment's changing, the experiences are changing, technologies are changing, how do we make sure the patient voice and whatever policy or systems change that we seek to enact, how do we keep them involved?
Yes, that seems like a really important question. I mean, I think there are two things that I would want to say. The first one is that we have to keep asking patients, right? So this didn't really play a key role in my initial remarks, but part of how I got into this conversation is that I was a pain patient, and then working as a bioethicist, I got interested in ethics and policy issues surrounding pain. And so that gets me invited to speak and advise and sit on panels and work groups. But there are millions of me. Most of them just don't have a PhD and an appointment at Johns Hopkins. And so we could be taking advantage of, massive amounts of data from our patients, from clinicians out there doing the work. And it doesn't always have to be from somebody who's a professor, right? So I think just inviting patients to always be part of the conversation is a really important part. But the more sort of academic answer is to just make sure that all of the recommendations that we come up with, remember that the goal is to provide patient-centered care. And so the goal of evidence is to provide patient-centered care. The goal of policy is to provide patient-centered care. And so a lot of what's happened during the last 20 or so years is that, out of fear, out of a sort of sense of urgency, which is very real because now hundreds of thousands of Americans have died from drug overdose, and it has been tied to our prescribing patterns. So there's this very real urgency, but some of our policy responses have, to put it plainly, just been very ham-fisted. And so we have, state policies, we have concerns by physicians about what will get them, looked at very closely by their state medical licensing boards. And so one of the things that I think is really hard about this is that we need policymakers and regulators and agencies to help us do things at the structural level, but we need those structures, policies, and regulations to keep patients at the center. And so they have to be nuanced, and nuance is really, really hard in policy and regulation. So I feel like I always have the worst, most awkward job in this sort of setting, because a lot of times my role is to say something like, yeah, we need policy and regulation and everybody needs to be at the table, but also don't tie physicians' hands so that they can't practice responsible pain care, because responsible pain care is responsive to the patient in front of them, and we need to empower clinicians. And so this has got to just go back to education so much of the time, that we have to educate clinicians much more robustly. So the last thing that I'll say is that it kind of blows my mind. I work with a lot of graduate students, medical students, residents, and fellows who work on this issue. And they expected that with the amount of patients that they would see in their career who come to them because they're in pain, right? That being such a leading reason to see your doctor, they expected that pain would be a big part of their medical education, medical school through residency, and then are just shocked to find out how little, how big that gap, that competence gap is, in fact, at the end of the day. So I just feel like we have to absolutely do better getting our clinicians feeling empowered and competent to deal with patients in a nuanced, careful ways. So sorry, that's like the least helpful answer possible. It's real hard.
It was not the least helpful. I think we're all in agreement. I think for a final question, and is just how does FDA fit into this discussion and into this, what is your ideal role in terms of collaborations or other actions towards harmonization, or that they could take further to further these many different efforts that you all have described? Maybe just a real quick response from you all, and then we'll head off to final comments. Graham?
Yeah, I've been pretty explicit about what I'd like to see the FDA do and listed out several of those. So I would really encourage the FDA to listen to educators who know how to engage and drive behavioral change, because we know how to do this, and let us do our work. A lot of restrictions and requirements that are well-intentioned are actually counterproductive and are getting in our way. So I would really ask the FDA to let us do our work with the flexibility that we need. And I think the second thing is ask the FDA to be directive to the RPC who has, tens of millions of dollars per year put into education that is essentially not being used to its maximal capacity. The money is there, the opportunity is there. We just have to let it sing. And the accreditors are here to be part of the solution, and we can do this work and support high quality education. We just have to be let do it.
Great, thank you. Michelle?
My comments were very similar in that I think we need to adhere to accreditation requirements and not have mandates, because it's better to have that we learn from best practices, lesson learned, and then see how we can apply that into the educational initiatives. And I think we should have more educational flexibility as we move forward.
Thank you. Alistair?
I just want to highlight, I think what has been said a number of times here, just sort of to amplify it from my perspective as an ER provider, and that is the importance of telling kinds of stories that change the narrative when it comes to addiction treatment. I think at the end of the day, if we are truly interested in behavioral change, we have to tell different stories about the patients we are treating. Ultimately, I think at the core of what is blocking a lot of docs from really caring and really having the intention to treat, meet the action, which is still a pretty big gap. We have to change the narrative around who is worth treating and who is not worth it, whose life matters and whose life does not matter, whose pain is worth alleviating and whose pain is not. And I still think that there's still too many docs out there who don't think that this is worth their time. And so helping to address that, I think, looks like telling the stories of people in recovery and making sure that those are connected back to the clinicians who are on the front lines treating those patients.
Excellent point. Lisa?
I would really like to see the FDA. I mean, we have seen some wonderful models, and I think the flexibility is really what I would like to see from the FDA, and to see which models work. I mean, there's wonderful things being done, and that we can move more toward competency models that are practice relevant, individualized, and I think that we will be in a much better place education-wise. Thank you.
Thank you, Lisa. Sean?
Well, I put forward 4 recommendations, which I think if implemented would have a big impact, but since you gave me the floor, I'll throw in a 5th. I was on a recent Lancet commission around addressing the prescription opioid crisis in North America and globally. And one of the findings that we put forward, there was quite the criticism of the REMS program by the FDA, because there's been a number of published reports showing that it didn't seem to have much of an impact. And so just adding in a 5th recommendation, whatever the FDA does, and I applaud the efforts here to improve it, they need to monitor, they need to choose clear-cut outcomes, monitor it, and use that information for continuous quality improvement, and not, kind of just put it out there and then, let it run on its own. We need to collect good quality data, good evidence on the impact of whatever the FDA does, and then use that information to improve the system.
Thank you. All right, Travis. Fix it. Fix it for all of us.
Oh, great. So most simply, when it comes to any time language goes out or something that could frame a narrative or a structure, one of the things that I would love is for the FDA and other similar institutions that have a voice and authority to start thinking about opioid prescribing as more like a relationship with the patient and less like a discrete event. And that could maybe get more to this idea that deprescribing is part of prescribing. And so you don't necessarily have competence because you learned what dose to use for a certain procedure. You also, in order to have competence, have to know what it's like to manage over the long term and how to deprescribe, what a tapering program looks like, et cetera. So thinking about it more as the establishing of a long-term relationship rather than the discrete handing over of I guess these days, largely digital prescription, but thanks.
Thank you. And I want to thank all of our panelists for an excellent conversation and for being the final presentation for a really robust meeting. So as we're closing, I want to give a very brief overview of some of the key themes that we've heard throughout this workshop. Yesterday, we covered important core competencies and identified key professional practice gaps. And today we got some expert perspectives on how to implement those competencies and address those gaps. Our first panel reviewed the various successful efforts, filling educational gaps by the VA and PCSS, AAFP, the CDC, and Project ECHO, educating providers in the entire care team on how to communicate with each other and with patients to create a non-judgmental environment with a capability to work with a patient to find treatments for pain or for OUD that are right for them. We've also heard about the value of and some opportunities for sharing knowledge and successful models, whether that be across providers, health systems, or government agencies. In terms of future directions, just now we heard about reimagining the definition of responsible prescribing to cover the full treatment life cycle from appropriate initiation, management, and discontinuation. With it in mind, our panelists gave some recommendations for filling the education gaps that we've heard so far in that life cycle so that we can continue to learn and improve through concrete collaborative efforts, aligning regulations and content, and providing better funding, amplification, and flexibility for existing models that work well, and close some thoughts on how FDA can best support those efforts. Before we go, I would like to take a moment to thank everyone who contributed to this excellent workshop. First, all the speakers and the panelists who continue to do great work in the space, who are in the field, who are facing these issues every day, and who took the time to share their expertise with us over the course of this workshop. In the coming weeks, we'll plan on publishing a meeting summary, highlighting some of the great insights and the key themes that we heard from our participants during this workshop. Thank you, as well to our colleagues at FDA's planning team for this workshop, including Gerald Dolphin, Judy Staffa, Marta Sokolowski, Jana McGanich, Mickey Hunt, Mark Liberator, Mitra, Ahubor, Alina, Anganustidas, Beth French, Claudia Manzo, and Doris Oth, along with many FDA contributors over the processing. I am so sorry for all the butchering of names there. And a big thank you to our team here at Duke-Margolis, including Thomas Rhodes, Katie Green, Duray Kim, Brian Cantor, Nancy, Alan Lapointe, Kaylee Probst, and Matt D'Ambrosio. And finally, a big thank you to our audience. Thank you for joining us for this workshop and have a great afternoon.